Good evening, and thank you everyone for joining us today. I am Ankit Dogra with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd. We, as the academic partners, are delighted to welcome you all to the International Conclave on Understanding Clinical Urogynaecological Practices organized by the West UP chapter of ISOPARB in association with Jhansi OG Society. Jagsonpal Pharmaceuticals Ltd is the maker of DIVATRONE 10 mg tablets of indigenously manufactured, affordable micronized dydrogesterone for a safer and smoother journey to the motherhood. Injection maintain of 250 and 500 mg depot 17 alpha hydroxyprogesterone caproate to maintain pregnancy till its term. Lycorate preg sachets of L-arginine lycopene in DHA for high-risk pregnancies. A warm and hearty welcome to all the esteemed faculty members and attendees. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on the Facebook and the link is shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights, as its complete recording will be uploaded there. Now, we welcome the program conveners, Dr. Rima Goyal, Treasurer, West UP Chapter ISOPARB, and Dr. Rashmi Sharma, Joint Secretary, West UP Chapter ISOPARB. We also welcome International Coordinator, Dr. Deepa Mukundan, Secretary, Trichy Obs and Gynae Society. Now, we request Dr. Reenu Goyal to kindly take the proceedings further. Over to you, ma'am.
Good evening. Good evening, all the delegates, chairpersons, esteemed chief guest, and special guest. It's time to say goodbye to chilly winter days and welcoming the beautiful spring season. Spring is the time to say, let's party. Holi bhi aa gayi hai, where flower bloom and so does the hope. With the spring festival, festive feeling also comes alone. But before that, let's learn something that is quite upcoming in gynecology, that is urogynecological problems. Understanding clinical urogynecological practices. Now, I invite my co-host, Dr. Rashmi Sharma, for further proceedings, and technical supporter, Dr. Deepika, Jagsonpal Medical Services.
Good evening, all of you. Myself, Dr. Rashmi, and now we'll start an academic session with the panel discussion. So, to start with the panel discussion, the topic of panel discussion is dilemmas in urogynecology. And to start with the panel discussion, I would like to invite my moderators. Our first moderator is our respectable and ma'am Asha Jain ma'am, and she's a director at SMS SA Hospital, and she's elected member of Chhattisgarh Medical Council, and she's an IMA Secretary Raipur, and she's the Vice President IMA Raipur, and she is the President of Raipur Obs and Gynae Society from 20 to 22. And we welcome you, ma'am, Asha ma'am, we welcome you. Our next moderator is Dr. Namrata Bharadwaj, and she's the consultant gynecologist at Bharadwaj Hospital and Laparoscopy Center, and she's the assistant professor at JN Medical College, Aligarh, and she has won many prizes and awards in paper presentations, and she has given Kamini Rao oration at AICOG Calcutta, and she has published many papers and indexed many journals and publications. We welcome you, ma'am. Kindly introduce our panelists, ma'am. Namrata, ma'am.
Yes, ma'am. Thank you. Thank you, everybody. I have the pleasure of introducing my esteemed panelists. The first panelist is Dr. Shubra Agarwal. I'll keep the introductions short just so that we can start with our scientific proceedings. Shubra is an MBBS MS from BHU, Associate Professor at Moradabad, has published various publications. She's the winner of Dr. Krishna Jain Gold Medal and Dr. Indumati Javeri Award at PICOG Agra. She also has the privilege of winning Dr. C.S. Dawn Award at PICOG Lucknow. My next panelist is Dr. Apurva Asthana. She's my junior from my alma mater, JNMC, having done her MBBS and post-graduation from there. She's the director of Phoenix Healthcare at Greater Noida and is currently the treasurer of Society of Menstrual Disorder and Hygiene Management. And the third esteemed panelist is Dr. Vani Puri, ma'am. She is a North Zone Coordinator of Sexual Medicine Committee, FOGSI, Secretary IMA Ghaziabad, and Joint Secretary IMA UP State. My fourth panelist is Dr. Taru Chaya. Ma'am is the Secretary of Jaipur Obs and Gynae Society, the Director of Bansal Hospital at Jaipur, and has special interest in the field of iris pregnancy, menopause, and infertility. And last but not the least, we have Dr. Suman Sinha. She has a very impressive CV, but I'll try and highlight a few points. Dr. Suman is a senior consultant at AHIVF and Fertility Center. He's the East Zone Coordinator of Medical Disorders in Pregnancy Committee from 2019 to 22 and has various posts, held various posts in Ranchi Obs and Gynae Society. She's the winner of Dr. Durusha Award and has various publications to her credit. I welcome all the panelists. Welcome all. We hope to gain from your knowledge and experience. Asha ma'am, may I hand over the proceedings to you for the first case?
So thank you, Dr. Namrata. So thank you, Archana ma'am, for giving me this opportunity to be a part of ISOPARB UP. And the topic that we are going to discuss today is panel discussion on dilemmas in obstetrics and gynecology. I hope we will be able to make it interesting because we are going to take very, very simple cases. Very simple cases. And me and my co-moderator, Dr. Namrata, have tried to make the cases short and succinct. So it is my request that please answer in short and really let's have a rapid fire type of thing because we have only 40 minutes to run this program. So a lady of 30 years, para 1, labor 1, had a forceps delivery 2 years back. Now she presents with flatus incontinence and fecal incontinence whenever she's getting loose motions. Any of the panelists may answer, please. What could this be?
It is anal sphincter must have torn there at the time of, and properly repair was not done.
So the technical term here would be
complete perineal tear.
Old complete perineal tear.
Maybe not complete perineal tear because otherwise it must have been clear at that time only. A small tear, and then also we have this type of problems. And
sometimes in home delivery, it happens to be complete perineal tear and they don't come to the doctors. So it heals by itself and makes a scarred perineum. So
here it's very clear that this is because of delivery.
Yes.
What could be the causes? What are the various causes that a woman, somebody gets a complete perineal tear and some people don't get it. So what are the causes?
Most important cause is stretched perineum, which usually occurs when there is breech presentation or occipito-posterior position, or there is
forceps application.
It can be a prolonged labor,
prolonged
labor, difficult labor, big baby, instrumentation,
yes. And not giving proper support is not giving at the time of delivery.
So here we have you've enumerated almost all of them. Another thing is an elderly primey or a rigid perineum. There is a precipitate labor, shoulder dystocia, or if there is already a scarred perineum due to any cause. This could cause, these are the obstetric causes. Are there any traumatic causes?
Yes.
Any local injury at the time of either coitus or accident?
Any fall on a sharp
Rape, rape victims.
Rape victims, yes.
Rape victims.
Cow horn injury, I have seen one.
Yes,
Because
agreed. Even I have seen that.
Even I have seen.
Injury, a young girl learning how to cycle and, you know, not having her own one and then just hitting herself and breaking the perineum. I've seen that also.
Yes.
So now what are the signs? She is a complete perineal tear. On inspection, what do we see?
So ma'am, usually there is absence of the perineal body. Then we can see dimpling on the skin, which are usually present at 3 and 9 o'clock position, indicating the external anal sphincters. Then there will be a radial fold of skins, which are usually seen around the anal verge. They are absent anteriorly because the external anal sphincter is not there. And there can be fecal swelling, which we can see, which continuously causes irritation of the skin around the anus. That results in reddish and inflammation of the anal area.
And also when you put your one finger in the anus and one in the vagina, you'll see
no, ma'am, we will come to that. What do you see on a Pspv examination? What are the findings when you do a PS and a PV examination?
Usually they are normal, ma'am, because the upper vagina and the cervix are normal. Sometimes we can see some sort of prolapse if the patient is having prior to it.
Associated, that will be associated.
Associated, like if she is having prior to it, then it can happen.
When you do a rectal examination and put your finger, another finger in the vagina, you see the both are so close together because there is no perineum.
Yes.
So
ma'am, that is a rectovaginal examination. When you do just a rectal examination, what are you going to find?
Absence of sphincteric tone.
Yes, you'll feel
exactly. Absence of sphincteric tone. You may also get hemorrhoids, you know, that you can see, or a rectal partial prolapse can also be seen. Now we come to the rectovaginal examination. Suman ma'am?
Yes, I've already told, I think. When you put your fingers in the one in the vagina and other in the rectum, and you feel that both are so close together, which usually doesn't.
And both the mucosas, sorry ma'am, Asha ma'am, both the mucosas, vaginal mucosas.
When you examine the pink color of
the mucosas can be seen.
We will not be able to feel the tone of inspector when we apply, put both the fingers together.
Yeah, you can see everything so close together.
So now what are the investigations that we can do? Are any investigations necessary?
Basically, a clinical
examination is sufficient. We don't need any investigation.
Yes. But in these days of medico-legal fear, would you like to do something? Would any kind of examination help?
Yeah, ma'am. Microscopic examination of stool, if there is any contamination or any worm infestation or any sort of infection, we have to treat it before we have to go further.
Most of the time, it doesn't help also. We cannot find out the
But just, ma'am, we can just, for medical legal purposes,
you have to rule out
hepatitis
B and you have to rule out hepatitis B and diabetes before.
So that is the preoperative that we are going to do. What do you think is the role of transperineal ultrasound?
Yeah, they do have, ma'am. They can assess the injury to the external sphincter, and the MRI can be used to assess the injury in the extent of injury in the internal sphincter.
Okay, so basically, you have a three-dimensional image of, you know, where the deficit is there. But basically, a good clinical examination works just as well. You really don't need to do that.
Yes. Most of the time not required.
What is the differential diagnosis?
It can be rectovaginal fistula also.
Yes. How is it going to be? How are you going to examine whether it is a rectovaginal fistula or just a simple tear? The woman has come with incontinence. So how are you going to investigate whether it is a rectovaginal fistula?
In case of tear, there will be loss of sphincter tone. That will not be there in case of rectovaginal fistula.
Yes.
And we can assess with the MRI also. If you want to go further in
a simple proctoscopy and a specular examination should do the trick.
For the high vaginal fistulas, we can go for a proctoscopy.
So how are you going to prevent this perineal injury? the patient is delivering, how are you going to prevent this perineal injury?
By perineal support. In vertex presentation, we should maintain the flexion always and put one left hand on the perineum to support the perineum so that the baby is delivered in flexed.
Timely given episiotomy.
And episiotomy should be also, I mean, judicious use of episiotomy also.
Ma'am, during the good intrapartum, we should give the episiotomy. During
perineal massage can be done 2 weeks before.
Warm compression.
Ma'am, in your experience, does perineal massage help?
No.
Means it's written there, but how many of you have actually given it to your patients? 2 weeks before delivery, start perineal massage.
We can teach. Actually, I have not given, but if we, because here we are discussing now, and we have to improve our obstetric outcomes, so we can tell our patient that they can themselves give the massage.
Yeah, agreed. But I means personally, I don't think I've advised anyone to go ahead and have a perineal massage.
I mean, if it is written in the book, suppose we go with it,
yeah,
maybe it will help in improving the obstetric outcome.
But you are also expert that I need to take an opinion from you personally, more than what is there in the book.
Ma'am, actually, perineal massage can help in ease of delivery, but it cannot help in protecting and or avoiding perineal tear.
Agreed. And what do you think can be the mode of delivery? Means compared to a difficult vaginal birth, would you prefer an easy cesarean?
Yes, yes.
Or you would prefer to go ahead with a difficult vaginal?
Always better than
cesarean section.
Cesarean section is always better.
And I would like to use vacuum also, because vacuum.
Outlet forceps are given, but difficult outlet
forceps will be acha if you give vacuum.
Vacuum. And preferably both the instruments should not be used together when both forceps and vacuum.
That is very, very important, at least for beginners. पहले एक से try किया नहीं हुआ तो दूसरे से पूछ लिया. So, and another thing is that you only try once, and if it doesn't work, you quit. You don't just keep on trying till it goes on slipping.
No.
When would you perform surgery? What is the time frame? If this lady has come after 2 years, but if somebody, if an injury is detected at the time of delivery, when would the surgery be performed?
Ideally within 24 hours or within 6
months. After 3 months, before 6 months.
Any particular reason for this? Why after 3 and less than 6? Why?
So during that 3 months, there is proper healing. Infection will...
there will be less inflammation and less infection.
Less inflammation, less infection.
After 6 months, more of scarring.
And the patient general condition will also improve.
Yes.
The tissue is so fragile. If we do less than 3 months, then it recurs. Even if the good repair is done,
it will worsen the condition. Failure of our.
Well said, Dr. Taru. And my 5th panelist, will you please rename yourself? I cannot see your full name and I cannot see you. I'm seeing everyone else. Dr. Taru, Dr. Shubra, Dr. Vani, and Dr. Suman, I can see. My 5th panelist, I cannot see. Dr. Apurva. So, Dr. Apurva, please, we would welcome inputs from you as well. So, this question has been very well answered. Now we go. What is the layered method of complete perineal tear repair? And next, we will go to the other method. What is the layered method and what is the Warren flap method?
Layered method is simple method when we suture layer by layer, mucosa, then immediately muscles, and then
the sphincters,
then the internal, external.
And what is the Warren method? Warren flap?
In this, we create an inverted V, and the flap is being put down on the anal verge, where an inverted V is created, and we just repair it. We repair the rectal mucosa, then we again repair the external anal sphincter, maybe by end-to-end or overlap technique. Both of them have shown same results and same outcome in long-term outcomes. Then we repair the vaginal mucosa. So
what I understood when I read this was that, you know, our seniors used to do a vaginal hysterectomy and the posterior repair where they gave an incision at the mucocutaneous junction. Yes. And then they gave a midline incision on the posterior vaginal wall, and after that they started removing the flaps. Now this is the basic method, and what they were doing after the midline. This midline is cut, and then the redundant vagina is cut out.
And they should cut
Here,
it.
instead of that, you have taken a primary incision like this, and then you repair the same way, and then you cut away the redundant vagina. So even though the names are different, basically the technique doesn't differ much. It's the same tissue that has to be sutured layer by layer. And now my almost last question, what are the complications of this surgery?
There can be infection, dyspareunia, recurrence can occur.
Recurrence, incomplete repair,
constipation. If
repairing
is being done.
Not able to hold a stool later on also.
Overcontinent. Patient can become.
So
deep
wound dehiscence is one thing if the edges have not been really freshened up very well. And a basic infection is always there. So with this, my esteemed expert panelists have just blown it. You know, you've been too good. And now I think I will hand over to Dr. Namrata to take her second case.
Yes,
Thank you,
ma'am.
respected panelists, and welcome, Dr. Namrata.
Thank you, Dr. Asha.
Okay, Dr. Asha, thank you so much. Okay, we go with the second case. And now in this case, I'll be asking pointed questions to each of you, just so that we can hurry up the proceedings. We have Mrs. A, a 35-year-old para 2, who presented with the complaints of increased frequency of micturition, dysuria, and pain abdomen. And this was the third such episode in the last 6 months, and there's history of DNC for missed abortion 6 months back. Physical and general examinations was normal. Urine analysis was done, and it was revealed pus cells of 8 to 10 per high power field, RBCs 4 to 5, and urine albumin plus. My question to Dr. Apurva, what is your diagnosis provisionally, Dr. Apurva?
Since the patient is presenting with symptoms of dysuria frequency and urine analysis is also showing pus cells, this is a urinary tract infection, and because it is more than 2 times in 6 months, this is a recurrent urinary tract infection.
Very correct, Dr. Apurva. So, Dr. Vani, what significant points should we ask in a history of a patient who presents with such symptoms?
So prior, we should ask about the prior she was having any infection in the previous history. And sexual history should be sought out. How many sexual partners are there? Any sexual transmitted disease, STDs, should be inquired about. Any history of douching or any history of using tampons and all should be sorted out. And fluid intake, patient's basic fluid intake should be asked for. And any history of indwelling catheter, if it was there, any hospitalization, whether the patient was there, any recent antimicrobial on which the patient was there. All these history should.
Very correct, Dr. Vani. What I wanted to impress upon, ma'am, can I have the next slide? Thank you, ma'am. What I wanted to impress upon was the sexual history and multiple sexual partners. Number of sexual episodes is a very, very important part of our history, which should never be avoided. And of course, medications, very rightly said, ma'am, very correctly answered. Thank you. The next question I would give to Dr. Taru. Ma'am, how would you define a recurrent UTI? What is the exact criteria for which we take a recurrent UTI? And what is the difference between a relapse of an infection and a reinfection?
Actually, there are two different identities. Relapse and reinfection. Reinfection is little like recurrent infection when it happens again and the same type of bacteria is not grown in this culture. And relapse is when, despite appropriate antibiotic is given for 15 days, patients still have symptoms and the same type of organism is there in our urine culture. So that is relapse. And reinfection is which she again predisposes for this infection is reinfection.
Yes, ma'am. So can I have the second slide, please, ma'am? So we define recurrent UTI as more than 2 episodes of uncomplicated UTI in the last 6 months or more than 3 episodes in the last 12 months. But please remember, these two have to be documented by culture. Just because she has dysuria, we will not call it a recurrent UTI. And as Dr. Taru very rightly said, relapse is the same bacterial strain, whereas reinfection is a completely different stain. Now we know that we need to have a urine culture examination when we talk of UTI. So, Dr. Suman, can you tell me the correct method of taking samples for culture? This is just a refreshment.
Yes,
all of us are taking cultures, but we need to tell them.
Cleanly catch specimen should be collected. And for this, we should separate the labia and clean the paraurethral area with a moist gauze or a tissue, and then should collect the midstream urine sample.
Yes, very correct, ma'am. A no-touch technique, a wide bore container, separation of labia is a must. Thank you, Dr. Suman. Very aptly answered. Now, Dr. Apurva, what investigations other than urine examination would you like to do in this patient?
Apart from urine, we have done a routine urine and followed by a urine culture in this patient. And apart from it, we would like to know if there is any pre-existing disease in the patient, like a routine blood sugar examination to know whether she is diabetic or not. Then further, if she is presenting with any symptoms of upper urinary tract infection, like fever or something like that, or flank pain, then an ultrasound will be required.
Yeah. That's correct. Ma'am, can I have the slide here? We have to understand that a lot of times all of us must have diagnosed subclinical diabetes in cases who have presented with recurrent UTI. So these are patients who should be caught in the OPD. We should be alert to the fact that maybe they are harboring diabetes. Of course, systemic involvement requires higher studies, which we will discuss later on. Dr. Vani, we have done a urine culture examination, and what is meant by significant counts in a urine culture? We always get those reports. Just a short.
Significant count is the count should be 10 raised to the power 5 colony-forming units per ml of the bacteria. That is significant. And in some view of thoughts, like they say that 100 colony-forming units per ml if the patient is symptomatic.
Yeah. What I wanted to, ma'am, can I have the slide, Dr. Asha, ma'am? Next to this one, ma'am, please. Thank you. See, this is one thing I wanted to be clear, that a lot of uropathogenic E. coli, they invade the urothelial cells lining the urinary bladder, which form the intracellular bacterial communications or a biofilm. You know, these are the patients who remain undetected in culture and they cause recurrences. You know, they present with, you know, unexplained dysuria, urgency, like something called bladder pain syndrome. Okay, thank you. Dr. Tharu, what are the factors predisposing to treatment failure?
Yeah, one important thing we should know, what is predisposing means those factors which influence and aggravate the condition. So in case of urine infection, there are many predisposing factors like menopause, old age, those where we have low immunity like pregnancy, diabetes, metabolic disorders, and inappropriate antibiotics given, and not for a normal period antibiotics are given. There is a short urethra, anatomical causes, maybe there is some short urethra or some cystocele where there is a retention of urine for a longer period, and the patient is sexually more active. These are common causes predisposing.
Yes, Dr. Tharu, and this is very important that as Dr. Tharu rightly pointed out, inadequate frequent treatments given in the form of antibiotics, they give rise to treatment failures later on.
And one more thing I want to highlight, which is not given in any books, but in practically we see nowadays there is a change in our system. We use hand shower or jets for washing. So E. coli reaches by those things towards urethra and vagina.
Very correct, ma'am. The current hygiene practices in washing
are predisposing washing by hand shower because it makes injuries also.
Sometimes yes, ma'am. Thank you, ma'am. Shubra, finally we come to you. What is uncomplicated and complicated UTI, Dr. Shubra?
Uncomplicated is associated with any kind of structural or functional abnormality, could be in the form of cystocele, vesico-ureteric reflux, maybe catheter-induced or prolonged hospitalization. Even pregnancy comes in a complicated UTI. These are factors.
Okay. And an uncomplicated, of course, we have a sporadic community-acquired episodes of cystitis, which may or may not lead to serious outcomes. Right. Now we come to a entity called asymptomatic bacteriuria. Dr. Tharu, what is asymptomatic bacteria and what is its significance in our clinical practice?
See, if the sample of urine is appropriately collected, we are sure that sample is collected properly, and there is isolation of bacteria in that sample, but there are no symptoms to the patient. It's like no frequency of urine, no pain, no dysuria, no symptom, no fever. Then we call it asymptomatic bacteriuria.
Yes, ma'am. And the significance is that if not treated, almost 40% of these women will develop symptomatic infection. So we should not be disregarding asymptomatic bacteriuria. Very correct, ma'am. My next question would be to Dr. Suman, ma'am. What are the indications of giving antibiotic prophylaxis? Or what are the protocols of giving antibiotic prophylaxis in recurrent UTI?
In recurrent UTI, actually, I prefer two methods. Either I like to give a low dose for a longer duration.
Yeah.
So my preferred drug is, I like to give NFT, nitrofurantoin, 50 to 100 milligram once daily for 3 to 6 months for recurrent UTI.
To start with, ma'am, or initially you will load with the proper antibiotic dose, and later on will shift to low dose.
That also can be done. Suppose she has come to me and she has been treated and she's not improving, then I can continue it for a longer time. Suppose I can give a loading dose of 100 milligram BD of NFT for 5 days, and then I continue with the lower dose for 3 to 6 months.
Shubra, would you like to add something, Dr. Shubra?
Some people even advocate phosphomycin sachet can be given.
Sachet can be
given for approximately 6 months. Then there can be postcoital prophylaxis also. Some people feel that after intercourse they have urinary tract infection kind of symptoms. So they can self-administer within 2 hours of coitus.
That is also, yes.
We have to take partners as well.
Yes, yes.
Partners also.
Can also be trimethoprim and sulfamethoxazole, but personally we don't use it. We prefer nitrofurantoin.
Cephalexin also can be given. Yes. Cephalexin.
Fluoroquinolone.
Yeah.
But in my experience, ma'am, I give metrogel along for 5 days because we have to stop anywhere E. coli also. Otherwise, it will keep on coming. No doubt it is.
Yes, E. coli can be very irritating and can be very resistant to infection. That's correct.
So the main aim is to prolong the treatment for a longer period. So that
usually, because as I said, these bacteria tend to lie low in the crypts and form biofilms and keep on giving recurrence. So you hit them and you hit them hard and you hit them repeatedly. That is the basic idea of antibiotics. Okay, Dr. Apurva.
Ma'am, I just want to add one thing, ma'am. Ma'am, in case of postmenopausal patients, we can add topical estrogen also.
We'll come to that, ma'am. We are coming to that, ma'am. We're coming to the non-antibiotic treatments, ma'am. Okay, Dr. Apurva, ma'am has already told us one non-antibiotic treatment strategy. Can we have more from you, ma'am?
Yes. Non-antibiotic treatment strategies is the daily lifestyle modification, increasing plenty of fluid intake. Apart from it, the role of D-cranberry is not very well supported by evidence. And proper perineal hygiene, wiping always from front to back, and using topical estrogen in postmenopausal women.
Exercises also, perineal exercises also.
Then sexual frequency, do not change sexual partners very often. They also lead to recurrent UTI.
Okay, now that is something which is really personal. We cannot talk that on our medical forum. So we have manos, lactobacillus like probiotics, ma'am. And a lot of other strategies that Dr. Apurva said. We have a few upcoming emerging therapies in recurrent UTIs. Some of them are under trial. Can we know what vaccines are now being formulated for recurrent UTI, Dr. Vani?
Vaccines, ma'am. Vaccines are
coming, but it's not yet available. I think.
No, they're not available yet. They're not. Just to complete the list, I had put this question here. We have those oral capsular vaccines,
OM89.
Abhi jo hai na, one capsule on empty stomach, they're saying for 3 consecutive months. Trials are going on. The Urovac, which is a suppository vaccine, has completed the phase 2 trial, and there are certain intranasal vaccines under research too. See, UTI is, and especially recurrent UTI, is something we deal with every day in our OPDs. I don't think 10, 12 minutes are enough to discuss, but thank you so much, my panelists, for giving your insights.
Vaccine is going to kill E. coli, but it will going to kill E. coli in intestinal flora also.
Nowadays, there are biomarkers also, na? Dr. Namrata?
Yes, ma'am.
Biomarkers are also there.
We'll go on and on. Otherwise, we cannot finish the panel in time. Thank you. Let's finish this recurrent UTI here and hand over to Dr. Asha for her second case. Thank you.
Thank you, Dr. Namrata. We are both managing in 11 minutes per case, So I think we'll be done in 45 minutes.
Yeah.
And this case is a really, really short case. So it's a 35-year-old, gravida 2, para 2, living 2, all vaginal deliveries. And she presents with deep dyspareunia, which we are going to call DDP now, for the last 6 months. Whenever a woman comes with deep dyspareunia, the first thing we think about is endometriosis. But now let's do some brainstorming. Is it only deep endometriosis, or could there be other things?
There can be pelvic congestion.
Congestion also. Then apart from
wait, ma'am, we'll come to that. I'm just asking you, how would you define deep dyspareunia?
In case it is posteriorly, deep dyspareunia, deep inside, posteriorly, anteriorly or laterally. Patient can very well tell. If it is very much anterior, then it can be some bladder infections also.
Ma'am, we are not saying that. I'm just asking you the definition of deep dyspareunia. How do you define deep dyspareunia?
Pain during sexual activity when it is very much inside.
Okay.
On deep penetration.
Deep penetration.
On deep penetration. So what is the incidence? How many women actually get deep dyspareunia?
Ma'am, the incidence is quite higher, but the reporting incidence is lower.
Very low.
Like it's around 70% or 74% like that, but the reporting incidence is less.
Ma'am, actually, if there has been a case of a chronic pelvic pain, the incidence is 41.2%. But if there is no chronic pelvic pain, then the incidence is only 13.8%. This is international data that we have. So if somebody is reporting chronic pelvic pain, then that person is more likely to get deep dyspareunia. Now we come to what are the probable causes. All the causes that you can think of.
One is endometriosis.
Then
Yes.
interstitial cystitis.
Interstitial cystitis.
Pelvic
congestion.
Pelvic congestion syndrome.
levator and myalgia.
Myalgia, yes.
Yes. The retroverted uterus is also.
Retroverted uterus and ma'am, sexual abuse.
Yes.
Sexual abuse.
Yes.
Even prolapse in a complete procedence, yeah, it can cause.
Not even simple cystocele can also cause.
Adenomyosis sometimes.
Ma'am, tentative causes can be adenomyosis, fibroids, PID, like
Ovarian
tentative. They're not even
previous surgery on the perineum.
Surgeries.
Ovaries.
Previous cervical tear, previous
Repair.
forceps injury, which have been repaired.
So a scarred vagina, basically.
Yeah, basically scarred
vagina.
A scarred vagina. So we've discussed most of the things.
Irritable bowel syndrome, ma'am. One
Yes,
is irritable bowel
agreed.
syndrome as well.
So we've discussed the causes. Now, how would clinical history differentiate the causes?
Ma'am, in dyspareunia, deep dyspareunia, which is due to the endometriosis, it will be positional, and it will be more when the menstruation is about to happen. So
Exactly.
it decreases
Cyclical.
when the
It would be
positional-
cyclical.
Yeah, and the positional, when there are changes in the position of the coitus, then it will be relieved.
So we have to ask patient when is the dyspareunia, when they feel throughout the cycle, cyclical, or at times in different positions, or what are the correct positions of the pain.
So what are do you think are the investigations? What are we going to do? If a woman comes with deep dyspareunia, how are we going to investigate her?
A transvaginal ultrasound.
Or an MRI can also be done sometimes.
Ma'am, you're going to examine her first, right?
First examination.
You know, she could have an infected Bartholin in the beginning. She could have a deep infected vaginal cyst. Let us start from the beginning because we have to cover everything.
First is examination, then blood examination routine, then we further go for further investigation step by step. If we find something in there, only then we go ahead.
Okay. One thing out of the way I'm asking you, have any of you ever seen a patient with vitamin D deficiency actually presenting with dyspareunia?
Yes, I've seen.
I think that is something we all need to remember.
I gave vitamin D and patient recovered very well.
So means you have to do vitamin D levels as well.
Yes.
Vitamin D and B12 levels.
B12 to ma'am.
Then as Dr. Shubra was saying, Dr. Shubra, you may proceed with your imaging techniques.
We can go for TVS or MRI in these patients to confirm any superficial endometriosis or any bladder infection can also be seen with thickening of the urinary bladder. Cystitis we can rule out.
And of course, any type of malignancies.
Malignancies usually are not painful.
Even
I'm scarring.
Yes, ma'am.
I want to say one very clinical causes. You know, so many times when the patient are, they are allergic to condoms or something, then they really complain of dyspareunia.
Psychological.
Okay. Okay.
That is psychological, I think, no?
Psychological.
No, she may really be allergic, ma'am.
Yes, she can be
allergic.
We will never allow.
Yeah, even sometimes vaginitis, and their complaint and very classical symptom they always experience.
Very variety of condoms people are using.
Pelvic inflammatory disease, prolapsed ovaries. Now, if it is deep infiltrating endometriosis, how would you like to manage it?
First, you can try with the medical treatment, and doesn't improve, then we can do laparoscopic excision of the
endometriotic lesion.
I'm excision followed by medical.
Yes.
Surgical excision of the endometriosis.
Actually, the medical treatment shrinks the size of the
diagnostic laparoscopy
and
then starting
even letrozole can be tried. Letrozole
medical treatment.
Nowadays, letrozole is also coming. So first you start with the medical treatment.
Even
the size of endometriotic nodules, and then you can do laparoscopic.
Even vitamin D is also helpful.
And vitamin D has a very good role, as Dr. Asha has.
So we've done with this, and now we go to the next. If it is due to pelvic congestion syndrome, then what is the role of ovarian vein embolization? Do you see any role of ovarian vein embolization?
We have never come across, but I think it will remove, it will lessen the pelvic congestion and the dyspareunia will.
By definition, it looks congestion will be reduced by this, but we have not tried.
Okay, so the thing is, we bring this up today that it can be tried if you have an interventional radiologist. Otherwise, women end up having a hysterectomy for no reason.
For no reason. Correct.
For no reason. So at least you can have this ovarian vein embolization. It would not really be very expensive also. And you can see for the results which will come up after about 3 weeks after the embolization. Now, if the dyspareunia is because of interstitial cystitis, how is it going to be managed?
Local injections.
Intravesical injection of lignocaine.
Intravesical injections of lignocaine.
Number one, cystoscopy, you have to see what is the grade of
nasal cells.
Okay. Associated urinary tract infection, that is one thing. And then interstitial cystitis is there. Then if you are going to give intravesical lignocaine, then what is the frequency? For how long you're going to do that?
Weekly for 3 weeks. Weekly for 3 weeks?
Ma'am, it's alternate days.
3 times in a week for 3 weeks.
For 3 weeks, yes, exactly. So that is the frequency where you're going to give it. Now, if it is levator and eye muscle myalgia, then how would you manage it?
Usually a multidisciplinary approach where a gynecologist, neurophysician, and everyone has to be involved.
And it's basically exercises.
Exercises of the levator.
So myofascial release is the last thing surgically done, but by exercises, it has to be myofascial release and pelvic floor muscle rehabilitation. So they have variety of instruments, they put in electrodes and this and that, but basically we would call it sort of placebo therapy. Now, this is one question. Do uterine myomas cause deep dyspareunia?
Not proven, ma'am. They do, but not proven.
Not proven. Depends on the position that they are in.
Posterior, quite deep in the pelvis.
Subserosal myomas are most likely going to give this type of pain. Patient complains.
So what we have the answer is that if a patient has a history of familial myomas, then 43.2% women have deep dyspareunia. But if it is sporadic, then 28.3% have dyspareunia. What this is telling you is that if it is sporadic, at least 2/3 women will have dyspareunia not because of myomas. So you need to really look for a cause. Otherwise, you treat the myoma and she comes back to you कि मेरी problem तो ठीक हुई नहीं, ठीक नहीं हुई. So when we are counseling, both kinds of counseling has to be done. Now, if there is adenomyosis, how are you going to manage it, which is causing DDP? If adenomyosis is causing it.
Medical management of adenomyosis.
Does it work?
Yes, it works, ma'am.
It works?
Size of the...
What medical management are you giving?
Depends on the condition of the patient, what is the age of the patient, how much, which para patient, family is completed.
Now you have this patient who's 35 years old. So what medical management are you going to give for adenomyosis?
If the patient is completed the family, I like to give letrozole and vitamin D. We will try for 3 to 6 months. Broken treatment of letrozole. 6 weeks, then we'll stop for some time. Again, we will give it response.
Okay. Okay. Thank you. So 26.9% of women with adenomyosis have DDP. Now, if a woman just has a retroverted retroflexed uterus, and you know the uterus and the prolapsed ovaries and the cul-de-sac are getting hit in heartus and giving deep dyspareunia, what is your suggestion for this woman?
Lie down prone for a longer little period. Positional. At times, she corrects retroverted uterus also. After one first
change the position also.
Yes. Anything else? Dr. Apurva? Would you like to add something?
Sling surgery.
Sling surgery also works. Okay. So the ligation of the round ligament also works.
But at our old times, we used to correct it manually also. Retroverted. At times it happens also. There is correction.
So how will you manage if the DDP is because of PID? Or tubes are inflamed? How are you going to treat this?
Medical management.
Medical management of PID.
Okay. How long do you try medical treatment of PID?
10 to 14 years. 10 to 14 years.
Hello. And supposing it doesn't respond, what next?
Dr. Nandita.
Or tubes remain swollen and hydropic, then what?
Hanji.
Doctor, 10 minutes are there.
Medical management.
If it is hydrosalpinx, then we need to surgically remove it laparoscopically.
Can't hear.
If it is a hydrosalpinx, it needs to be removed laparoscopically.
ATT can be tried, ma'am.
The recent guidelines for AKT are, ma'am, that without proof you cannot start it.
I know.
So we need to get the proof first. Now, if it is IBS, then how are you going to manage it? because 16% women with IBS have deep dyspareunia. How is this IBS going to be managed?
Usually medically antispasmodics can be tried.
Antidepressants only work on this.
Yes, ma'am?
Antidepressant drugs only work on IBS.
No, ma'am. There are specific drugs, antispasmodics, that can be given and they work.
They work, ma'am, but antidepressant they have to be given for IBS because basically IBS is related to psychological dysfunction.
Do you all agree to this?
Right.
Irritable bowel syndrome is psychological. Do you all agree to this?
A lot of IBS has a lot of pathology, Dr. Archana, I feel, because there's no infective pathology involved, and stress is a big factor in precipitation of IBS.
Agreed. But what now we find is that a lot of things that are labeled IBS are actually celiac disease.
Yeah.
And you are labeling it psychological and giving antidepressants. You need to get the woman tested for celiac. If it is negative only, then you can label her as a clear IBS and then treat her accordingly.
But that is IBS. Celiac disease are different. Then we cannot call it IBS.
Ma'am, but actually IBS is a symptom of celiac disease, which has many composite problems. So that is one of them. So if there is a history of sexual abuse, what would be your next step for DDP?
Counseling.
A lot of counseling, psychological support from
Counseling will be required.
Have to
Tender love and care.
Yes.
Okay, the woman has come to you and her husband doesn't know that there has been sexual abuse in the past. How are you going to handle it?
Dr. Asha, time is over.
Yes, ma'am. Just handing over to the next case.
No,
so this is case number 4.
Dr. Reno, do we have time for this?
Yeah, we are going to start.
I think we should wind up.
Okay, let's wind up. No problem. Okay, we were having a case of stress incontinence. Maybe sometime later we can have. No problem, ma'am.
Dr. Asha ask and give answers so that we all know.
Okay, I'll tell. We were talking of stress incontinence, ma'am, just winding up in 5 minutes. This is a lady, 45-year-old lady, who presented with involuntary passage of urine on coughing and sneezing, and no dysuria or increased frequency of micturition. We can quickly have our answers. Dr. Suman, what is your provisional diagnosis? We'll wind up in 5 minutes.
Incontinence.
Yeah, urodynamic stress incontinence, now we call it, which was earlier called a genuine stress incontinence. So what clinical tests, Dr. Shubra, would you like to do? Quickly, just enumerate.
History taking a clinical examination, we can go for a simple cough test. Then post-coital residual urine can be done.
Yeah.
These are simple tests.
Yeah, simple test. Just a simple clinical examination, I think, should suffice in getting to a diagnosis. Now, our patient, a Q-tip test I've just included, but I don't know, we are not doing it right these days. Now, this patient's urine analysis was normal, and ultrasound showed normal residual volume of urine, and cystometric studies showed normal litrussal activity. So now we have leveled this case as a case of genuine stress incontinence. Dr. Apurva, what lifestyle modifications and measures would you suggest?
A number of lifestyle modifications is needed before we actually go over to the pharmacological management. Some most important is weight reduction and monitoring her, telling her not to take a lot of alcohol or caffeine if she is taking, smoking cessation, and asking her to be very physically active, avoid constipation, and also take history if she's taking any diuretics or any adrenergic or anticholinergic drugs, which is also very important.
Yeah. Pelvic floor exercises, we have to explain.
Kegels exercises. One thing just I want to interrupt in between, I'll say that a fluid restriction per se does not help. In fact, she should be counseled that she should have no fluids 2 hours prior to bedtime, number 1. Yes. Number 2, a bladder training kind of program should be carried out, in which they should be scheduled voiding without urge. You know, this is set to improve urge and stress incontinence. So bladder training is a very important part of her counseling. And of course, as ma'am rightly said, Kegels exercises are the mainstay of treatment in these cases. What are the indications of aerodynamic study testing, Dr. Taru?
We need to just discuss in detail one day, pura full Kegel exercises. This is a must for all.
Basically,
Yes,
indications is this urgent incontinence or stress incontinence or neurological incontinence for this urodynamics test.
Yeah, nice guidelines say that when the diagnosis is uncertain, even after history and examination, you need to find out where you're going wrong. And various other guidelines, ma'am.
What is the cause of the
yeah, what is it to ascertain the cause basically? You know, Dr. Vani, what are the suggested medications? Quickly,
ma'am, we can use alpha adrenergics, we can use beta antagonist, we can use TCS, tricyclic antidepressants like amipramine, and the most promising drug is duloxetine. We can use that. These are the four drugs.
Okay. Dr. Suman, back to you, ma'am. What are the indications of surgery and how will you select the choice of surgery in these patients?
Surgery actually is indicated when all our conservative treatment fails. And when we want to, when the incontinence, when the stress incontinence part predominates, then you'd like to do a surgery. Or when you feel that urethral, overactive urethral hypermobility. When the urethral hypermobility is there, then we can do. Or when we are doing a concomitant surgery, like for the prolapse of uterus. Or
a lot of patients with genital prolapse have concomitant stress incontinence, and we can just repair it in this. So, Dr. Shubra, let's have the names of surgical procedures, the classical ones and the newer techniques. Just names.
The classical one were retropubic Corporal Suspension, which we are using, Bursch and MMK procedure. Nowadays, TVT and TVTO has gained popularity, which we are doing. Usually transobturator tape we insert. Now again, Bursch is regaining popularity. Now there can be periurethral bulking agents which we can use. So approved one are usually, which we are using periurethral bulking agents, are usually Durasphere, or we can use contingent. Then there can be advances like laser. Everywhere laser is coming. So even in stress incontinence, there is emerging role of laser which is coming up.
Yeah, so Botox, you know, Botox is not only for face, not only for lips. It can be used for.
Also, they're trying.
Botox injections there also.
Thank you so much. Thank you, Dr. Asha, ma'am. And thank you, my panelists. Very quickly.
Thank you so much. Nice, vibrant
Archana, ma'am. Rapid fire questions. Very nice.
It has to be rapid fire. No time now. Archana ma'am, thank you so much. Seema, Dr. Seema, thank you.
Archana ma'am, time पे complete हो गया?
Yes, thank you, ma'am. Excellent panel discussion in time.
Thank you.
Again, ये दिल मांगे मोर, ये तो बहुत जबरदस्त panelist थे, and I'm really impressed. And moderators, of course, तो ये तो पूरा 3 hours का solo show दोबारा चलेगा.
जी मैम, जब आज्ञा दे मैम तब.
In detail. Very soon, because ना अभी momentum बना हुआ है, तो momentum, so then we will be doing it, and in detail Kegel exercises and everything. I think this is something after very long I could see the beautiful this panelist involvement. I must say, really.
Thank you so much.
Thank you, ma'am. Panelists and esteemed guests, esteemed moderators. Thank you so much. You are well in time.
Thank you.
Dr. Asha, you were too good.
Thank you, ma'am. Thank you.
Thank you, Dr. Namrata. Very good.
Asha,
thank you, ma'am. Thank you. Were excellent, ma'am. All of you. That is how you could complete the panel in time.
Okay.
We have a 1 minute break here, ma'am.
Yeah, we can have 1 minute break then.
For the first time in India, micronized dydrogesterone.
I'm here, dear. Archana. I'm
for
here.
a safer and smoother journey to motherhood. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
Very good evening to all the esteemed faculty members and attending doctors. On the behalf of the sales teams of Jagsonpal Pharmaceuticals Ltd, we seek your support for our products DIVATRONE 10 mg tablets of indigenously manufactured affordable micronized dydrogesterone for luteal phase support in IUI, recurrent pregnancy loss, threatened abortion, and IUGR. We take immense pride in sharing that with years of R&D, Jagsonpal Pharmaceuticals Ltd is successfully manufacturing the high-quality API micronized dydrogesterone with all the intermediates, making India Atmanirbhar for producing this critical API. The quality of our brand DIVATRONE is backed by the bioequivalence study to prove its clinical efficacy and safety. With these clinical advantages, DIVATRONE offers a safer and smoother journey to the motherhood at a remarkable reduction in the cost to the patient, providing a more economical therapy at just ₹50 per tablet. DIVATRONE is readily available at all the counters near you to prescribe. Other excellent products from our product portfolio are JP Tone Syrup of iron, zinc, and vitamin B complex to promote well-being and restore vitality, and Lycorate soft gel capsules containing world process patented complex Lyco-Meto, all natural extract containing lycopene along with zinc and selenium. Our sales team visiting you is continuously striving to make your bulk purchase experience effortless and worthwhile. We thank you for this opportunity to connect with you all and look forward to your support for our brands.
Thank you, Ankit. So now, ma'am.
अच्छा हुआ जो गुजर गया फरवरी महीना, ये इंग्लिश मोहब्बत का महीना था दोस्तों। राधा कृष्ण का प्रेम तो अब चढ़ेगा, रसिया पर फागुन का रंग जब चढ़ेगा। इसलिए ऐसे मनाना होली का त्योहार, पिचकारी से बरसे सिर्फ प्यार। ये है मौका अपनों को गले लगाने का, तो गुलाल और रंग लेकर हो जाओ तैयार। Now I request our chief guest, patron, आप सबके मनपसंद Dr. Malhotra. Now I invite our chief guest, guest of honor, special guest, Dr. Sneha, अपना dynamic, vibrant, big boss, West UP chapter president Dr. Archana Verma, pleasing chairman secretary Dr. Seema Vaishnav, and all the delegates and dignitaries for the lamp lightning to see the of God Almighty.
Dr. Narendra Malhotra is here, ma'am.
Yes, good evening, everyone. Good evening.
Good evening. Namaskar, sir.
Namaskar.
Time nahi hai sir ke paas.
Namaste, sir.
May I
Namaste,
request
namaste.
Dr. Deepika to play the video of lamp lighting?
Dr. Narendra. Birthday of
Thank you, thank you, thank you.
Wishing Nanaji, Dr. Narendra Malhotra for his grandson Navkar birthday, Dr. Niharka's son. जन्मदिन की बहुत-बहुत बधाइयां. Congratulations, Dr. Narendra.
Thank you, thank you.
Now I request Dr. Archana Verma to welcome and introduce our chief guest, Dr. Narendra Malhotra.
Welcome the star of the FOGSI and everywhere who, there is no word I can say in 1 or 2 seconds that we have our patron, our chief patron, Dr. Narendra Malhotra, and we all know how dynamic he is, always smiling, always motivating everybody. और बस ये खुद ही को कर बुलंद इतना कि खुदा बंदे से पूछे बता तेरी रजा क्या है। इसी के साथ हम वेलकम करते हैं डॉक्टर नरेंद्र मल्होत्रा का टू ब्लेस अस विद ऑल द गोल्डन वर्ड्स।
ना कोई और आप सीखो, अब बार-बार वही बोलती हो।
ये बहुत चल रहा है, हम एक ही पे कह रहेंगे। कोई और हमारा जैसे मोदी है क्या ना, मोदी जैसे है नमो नमः। तो
So thank you very much for inviting me here. Thank you very much for all those lovely wishes for Navkar all of you have given on his happy birthday. Yes, I am in the party, as you can see, and there's a lot of music and you can see children jumping around, which is actually life. जिंदगी अब यही है कि इन बच्चों के साथ और इनको संस्कार देके बड़ा करना. So education has totally changed, and that is what this webinar has brought us so close to each other that even during personal functions, we all can meet and we all can say hello at least for a few minutes and learn and do so much of academic exchange. So that is what is there. So as I told you, party वहाँ चल रही है और जयदीप और मैं यहाँ हम दोनों एक वो दूसरा अटेंड कर रही है. So congratulations, all the best. All the best to this webinar. It is doing very well. I just heard it at 5 o'clock. Thank you for these lovely photos. Whoever's put it, thank you very much. Seema, Archana, all for all the personal love and touch you've always shown to our family. And best wishes for this great webinar. Thank you.
Happy birthday to little one.
बर्थडे पे हम लोग इंटरनेशनल वेबिनार कर रहे हैं along with डॉक्टर रीनू, डॉक्टर सीमा, स्पेशली डॉक्टर दीपा फ्रॉम त्रिची. एंड ये हमारे आइसोपब का आज इनॉग्रेशन, एक तरीके से पहला इंटरनेशनल वेबिनार.
ये भी एक बर्थडे हुआ मैडम.
Now I invite Dr. Seema to welcome and introduce
नंदिता का टीवी लगाओ. डॉक्टर नंदिता है आ गए क्या?
Now let's invite today's chief guest. And first of all, very good evening to all of you. And I welcome you all. Myself, Dr. Seema Vashne, Secretary West UP ISOPARB. Extend a very warm welcome to all. And my gratitude to President ISOPARB, Dr. Usha Sharma, Secretary General Dr. Meena Saman, and Patron, Professor Dr. Narendra Malhotra, and Professor Padam Shri Dr. Usha Sharma ma'am, and Guiding Force President West UP Dr. Archana Verma for giving this platform, such a prestigious platform, always full of galaxy of stalwarts. And today also we have a very good galaxy of stalwarts. As chief guest, we have Dr. Narendra Malhotra sir, our legendary guru, and Queen of Hearts, favorite for all, and especially mine, Dr. Nandita Palshetkar ma'am, as chief guest. So, may I invite Dr. Nandita Palshetkar? I think she's not yet joined, but I can introduce or not, Dr. Archana? Should I introduce?
Word for Dr. Nandita. Dr. Nandita has been a phenomenal person and making all of us feel so much empowered. And when she was the president, she let every woman of India felt that she is a Stree, and we for Stree, and we were there to just always look and maintain that it's for women empowerment, and how the education and financially independence and can make anyone feel very, very happy and empowered. Because for women empowerment, just greeting from FOGSI also, because this year's whole of the day and the daily we are making this all the efforts for violence against women. It is our prime agenda. And when Dr. Nandita was there, she made it very clear. And now we all are with Dr. Nandita for all her future endeavors. And you always have supported us. And so we expect all of us, you can rely on us that we all are there always with you. Thank you. And whenever Dr. Nandita comes and joins, we will be very happy to listen to her.
Okay. Now, thank you, Dr. Archana Verma ma'am. So may I invite you officially to say a few words? You want to say something as guest of honor?
Yes, already. Now you invite Dr. Sneha.
Okay. So it gives me immense pleasure, and I am very delighted to invite our special guest, Dr. Sneha Bhuyar. And she's chairperson study on female breast committee FOGSI 2019-21. She's governing council member ICOG 21-22, associate member of RCOG, managing director Sukharta Hospital with 29 years of experience in OBS-GYN, both in government medical college and private practitioner. And she has delivered more than 300 talks in state, national, and international conferences. She has received many awards in her accolades, and she has published so many papers. So over to you, Dr.
Thank
Sneha.
you. Yeah, thank you, Dr. Seema.
Your pulse of wisdom.
Thank you so much, Dr. Seema, for that very kind and generous introduction. A very good evening to you all. Respected NM sir and Nandita ma'am, today's chief guest, the conveners, Dr. Renu Goel and Dr. Namrata, of course, the very vibrant president of West UP chapter, Dr. Archana Verma, my friend, philosopher and guide. Today's speakers, Dr. Uma, Dr. Mridula and Dr. Deepa, moderators, Dr. Asha Jain and Dr. Namrata, all the panelists and chairperson, and of course, all the viewers. A very good evening to all of you. First of all, I would like to thank Dr. Archana Verma for inviting me here. And I would like to congratulate the chapter for selecting this topic and roping in illustrious speakers on this very important, most useful clinical topic, but least discussed. And I'm sure all these illustrious speakers are going to have wonderful deliberations, and it will be very, very beneficial for all the viewers. Once again, thank you so much for having me here. And I wish all the success to this program. Wish best wishes to the chapter and a very happy Holi to all of you. Thank you so much for having me here.
Thank you, ma'am.
Thank you, Dr. Sneha, for your kind words and for all inspiration to us. So we know the urogynaecological problems in women increase at age and requires a very holistic approach to relieve the patient's symptoms and need expert skill to overcome demands from aging female population and fulfilling the patient's expectation. Today we are having very eminent speakers, Dr. Deepa, and two very renowned and glorious international speakers, Dr. Uma Bathula and Dr. Manju Anappa, to enlighten us with knowledge and global perspective today. So we all welcome today's speakers and with folded hands. And now we start academic session over to Dr. Renu for further proceedings. To start with academic session.
Okay, thank you, Dr. Seema.
One minute, just let me say, really thankful to you, Sneha, and because Sneha is somebody who introduced me to ISOPARB, because she was a founder president of Vidarbha ISOPARB chapter, and she only took me to a journey of ISOPARB, I must say, and my super friend Sneha. She is such a great person and always supporting, always helping each other.
Thank you so much, dear Archana. Thank you.
Take many of us in your committee, actually. All the persons who are interested, do ask them to join. We want so many people to join FOGSI now. Okay.
Definitely, all of you are welcome. With Dr. Archana's suggestions, we can have many of you, we can rope in. Thank you.
Thank you, Dr. Archana, Dr. Sneha. Now, moving forward, I am going to invite chairpersons of first talk, urinary incontinence, Dr. Rekha and Dr. Neerabhan. Dr. Rekha? Dr. Rekha is chairperson, infertility and AR community, medical director, Miracle IVF Hospital and Chandra Hospital, Bangalore. Welcome, Dr. Rekha.
Thank you.
Dr. Neerabhan, senior obstetrician and laparoscopic surgeon at Ghaziabad, product of Lady Harding Medical College, New Delhi. Ma'am, you are welcome this section. Now I invite our national coordinator, Dr. Deepa. Dr. Deepa will welcome our international speaker, Dr. Uma. Dr. Deepa.
Yeah. First of all, a very, very good evening to all the stalwarts and eminent faculty and all the delegates here today. Sincere thanks to Dr. Archana Verma for giving me this opportunity to be a speaker, as well as the international coordinator for such a wonderful webinar. Thank you so much, madam. You're such a dynamic person and one of my mentors as well. And we have very eminent speakers for today joining us from UK, Dr. Uma Batula. She is an eminent urogynecologist and a very accomplished gynecologist and obstetrician practicing in Stoke-on-Trent, UK. And we also have Dr. Manjula Annappa joining us from UK. I think we started off with a bang. That was a wonderful panel discussion that we had, and a fantastic inauguration as well. And we are in for more treats from the international speakers as well today. With pleasure, I welcome Dr. Uma Batula. Just to mention, it's very sweet of them to take time off during a working day, during the working hours, just to be with us in our Indian time. So thank you so much, both Dr. Uma as well as Dr. Manjula, for your time and effort in joining us today in the middle of your hectic schedule. Over to Dr. Rekha Rajendra Kumar, who's the chairperson. She will be introducing the speakers for the first session. Thank you.
Thank you, Dr. Archana Verma. Thanks, Dr. Deepa, for the nice and brief introduction on me. It's a great pleasure to introduce one of the reputed international speakers, that is Mrs. Uma Batula. Madam is MBBS, FRCOG. She is also Diploma of Faculty of Family Planning and Fellowship in Minimal Access Surgery, Diploma in Minimal Access Surgery from University Hospital of North Midlands, Stoke-on-Trent. She is also consultant gynecologist and obstetrician, and she is the British Society Urogynaecology Clinical Governance Committee member, educational and clinical supervisor, MRCOG Part 3 Clinical Skills Course faculty. She's finished her MBBS from a reputed institute of Pondicherry, that is JIPMER. She's also a holder of Diploma of Faculty of Family Planning from UK. She's finished her MRCOG in 2004, and in 2005, she has done her PGA in medical education. Over to Dr. Uma Batula. We are here to listen to your very interesting topic and a day-to-day topic. I'm sure you will entertain us with your topic and will take home a lot of information from you. Over to Dr. Uma. Thank you.
Thank you, everyone. It's lovely to see so many Indian, really lovely faces with colorful clothes on, because we in the UK are so restricted. We only wear gray and black and very rarely brown. Never mind. And it's Holi time, so happy Holi to all of you. With not much ado, I'll just start sharing my screen. So that's as briefly as ma'am just now explained, this is my little resume, what I have done over a period of time. These are the positions I'm holding at present. A little about myself. I'm married, I've got 2 children. I trained in Bharatnatyam and I love Bollywood. I think most women understand what it is, because I think 3 out of 5 women have suffered some kind of incontinence in their life. And incontinence in itself, if we start academically, it's an involuntary urinary leakage, and 10 to 52% of adult women have some form of incontinence. This is according to the NICE guidance in the UK. We have various kinds of incontinence: stress incontinence, urge incontinence, mixed incontinence, and overflow incontinence. I'll talk briefly about each one of them. So stress urinary incontinence is a symptom and sign found on examination, but not a pathophysiological diagnosis. Women with stress urinary incontinence, approximately 40% of women report symptoms during their life. Women with the symptoms of SUI report leakage of urine during periods of increased intra-abdominal pressure, such as coughing, sneezing, and exercise. They may also report coital leakage during penetration or during intercourse. This affects up to 2/3 of women, but may not be voluntarily, during consultation, they may not voluntarily tell these informations. So the causes, as we all know, the majority of women with SUI are because of a urethral hypermobility. The risk factors of this include aging, childbirth, particularly vaginal delivery, and obesity. Women with connective tissue disorders such as Marfan's or Ehlers-Danlos syndrome are also especially at high risk of SUI. So the second form of incontinence is urge urinary incontinence, which is due to a condition called overactive bladder. And it is defined as urgency with or without urge incontinence, usually with increased frequency and nocturia. In most cases, the cause of the overactive bladder is unknown. In some cases, associated with a neurological condition such as multiple sclerosis or Parkinson's disease. So this is a little picture just demonstrating what kind of muscle tone gives this overactive bladder. So when these women come into clinic, history kind of takes a large part of what kind of incontinence the woman has got. So at the first appointment, it's important to kind of categorize what incontinence they have got. Some of them might have a clear-cut stress urinary incontinence. They will definitely tell you that the incontinence is only on exertion, such as coughing, sneezing, or doing any exercise. Others might say, no, I don't have incontinence while doing any activity. If I think of the loo, I have to go to the loo. That is, if I have to go, I have to go. That is urge urinary incontinence. It could be accompanied with an urgency. Some people may not have urgency. Without any notice, they may start having leaking. And then people have mixed urinary incontinence where they cannot decipher whether it's activity or whether it's just an urgency which makes them leak. So women with stress urinary incontinence describe this leakage, as I explained, typically with an increase in the intra-abdominal pressure. Some people have something called giggle incontinence, loss of urine when they have uncontrollable laughter. When a group of women get together, we do have uncontrollable laughter sometimes, and many women have this, which is actually stress urinary incontinence. They may describe the leakage with intercourse, or the leakage with orgasm is more likely to be due to overactivity. So Urogynae history must include inquiry regarding symptoms of overactive bladder. The proportion of women with additional overactive bladder along with stress incontinence will only come out on taking your history further. Some may have voiding dysfunction where they may go to the loo and might have to wait for some time to start a stream. Things like dysfunction in the voiding can only be obtained by getting a further history. The history about desire for future childbearing and contraception is important because you're tailoring the treatment, and the treatment depends upon the girl's further for the childbearing wishes, and whether they've had any previous treatment for incontinence. All these have to be included in your history. Further history is any medical comorbidities, because certain conditions can cause incontinence, and those conditions have to be treated before we actually treat the incontinence itself. Certain drugs which may impact your future treatment, for example, if patients are on antiplatelet treatment or anticoagulation, then if you're going to do any further treatment, these will have an implication. And of course, neurological disorders, as I mentioned earlier. One of the commonest advice we give in clinic, I'm sure all of you do as well, is the fluid intake. I always ask how many cups of tea or coffee they drink. I always tell them there are 5 things which you have to drink only, take it only as a treat: coffee, tea, hot chocolate, fresh orange juice, and anything fizzy. Being a cold country, UK, all of us reach for a cup of tea all the time for a hot drink. And the old women who stay at home drink cups and cups and cups of tea, and they all have incontinence. So fluid intake and tailoring, that is very important. We keep drumming this to every patient. Of course, smoking status, I don't think that's a problem in India as yet. Next slide. The previous one. So on examination, the most important thing is to check the patient's BMI, because heavier the patient, that amount of pressure goes on to the pelvic floor. So whatever weight the patient is, it's important that we discuss about their BMI. And along with that, we also look at abdominal palpation to rule out any large masses, palpable bladder, or any other abnormalities which could be pressing on the bladder. Vulval inspection, mainly to see the condition of the skin, to see any urinary leakage, and also any urethral abnormalities. Vaginal examination, again, to check if there's any prolapse or any urethral abnormalities, which could be kinking the urethra. Investigations, all women with incontinence should be asked to complete a 3-day bladder diary. And we in the UK, because the first port of call is the general practitioner, most often we advise the general practitioner to send them off the forms where they can fill. Sometimes if the general practitioner hasn't done that, then my secretary sends them before they come into clinic. So we know what is their voiding habits. And we also undertake a urine dipstick, and this kind of to rule out any urinary infection which could be causing a kind of incontinence. Other investigations, measuring post-voidal residual volume by bladder scan or catheterization in women with symptoms suggestive of voiding dysfunction or recurrent UTI. Bladder scan is preferred because it's less invasive and more acceptable, and less incidence of introducing any infection. So other tests which most urogynecologists will be familiar with is the urodynamic studies. This is a general term for the study of the storage and voiding function or dysfunction of the lower urinary tract. So all those terms are self-explanatory, and I don't know the practices in India, but in UK, after the initial treatment, if things don't improve, we straight away send them for this test. Urodynamics are not required before primary surgery if the patient's predominant complaint is only stress urinary incontinence and there is no overactive bladder symptoms. Our guidance says that there is no need to put her through an invasive test like a urodynamic study. And if you're going to do a primary surgery, then you can go ahead and don't ask for urodynamics. Urodynamics before surgery for stress urinary incontinence is predominantly only in women who have any of the following, like urge predominantly mixed urinary incontinence or urinary incontinence which the type is unclear, symptoms suggestive of voiding dysfunction, or anterior or apical prolapse, or a history of previous surgery for stress urinary incontinence. For these women, urodynamics is a must. They advise us in our guidance not to do cystoscopy as an initial assessment of the women with urinary incontinence as a standalone procedure. Other imaging, do not use imaging like MRI, CT, or X-ray for the routine assessment of women with urinary incontinence. Do not use ultrasound scan other than for assessing the residual urinary volume. Non-surgical management of urinary incontinence, lifestyle interventions. Lifestyle interventions, commonly, as I explained, we talk about the fluid intake or recommend a trial of caffeine reduction, women with overactive bladder. Also to modify the fluid intake. If somebody is having a lot of coffee and tea, we normally advise them to cut that and have maybe a hot water or drink plain fluid, which has got nothing fizzy in it. And of course, reduction of BMI. I think obesity in itself has become a big issue all over the world, and it has got a big implication on the bladder as well. So all women with a BMI of over 30 should be advised to lose weight. Normalizing the BMI is important in reducing the risk and increasing the chance of cure of any invasive treatment, especially if you're going to do any surgical procedures. Our guidance says that the BMI has to be closer to 30. Reducing the BMI below 30 reduces the leakage as well. Physical therapies, pelvic floor muscle training. We have a whole department of physiotherapists who deal with pelvic floor, and they do a wonderful job. As the first port of treatment will be after lifestyle changes is physiotherapy. A trial of supervised pelvic floor muscle training of at least 3 months duration as first-line treatment to women with stress or mixed urinary incontinence. Pelvic floor muscle training programs should comprise of at least 8 contractions performed 3 times per day. Again, guidance shows that a percentage of 20 to 52% of patients improve with just physiotherapy. Other non-surgical treatments include electrical stimulation, behavioral therapies, neuromodulation, like PTNS, or catheters, products to prevent leakage. If you go to the National Institute of Clinical Excellence, which is our guidance, they give you a whole load of things which you can try. But theoretically, this may be possible, but practically not many of these are possible. Medical treatments for overactive bladder, anticholinergics is the first port of call. The reason being easy to administer. Things like sulfonazole succinate, oxybutynin, trospium chloride, physioterdin, these are all nice recommended medications. In our unit, we try 2 anticholinergics before we give them anything operative. More recently, mirabegron has become very useful as the side effect profile is much less for it. All the anticholinergics have a side effect of dryness of mouth and constipation. Women, as it is in this age group, have both problems. So we go for mirabegron as a first-line medication, except in women where it is contraindicated, like if they've got blood pressure or have had any cardiac issues in the past, then mirabegron won't be their first-line medication. As mirabegron works through as beta-3 agonist, its side effect profile is very less. It does not cause mouth dryness. As a result, people are more likely to carry on taking the medication. So invasive procedures for overactive bladder, Botox injection to the bladder is quite common and quite prevalent in UK. And we give usually 100 units as the initial dose for a type A to treat overactive bladder in women. If there is inadequate symptom relief, we consider increasing it to 200 units. Although Botox is quite affordable treatment, we normally do this after an MDT discussion where a few of us urogynecologists sit together and get the approval that this is the right treatment for the patient. And even for repeat dosages, we take them to the MDT. Percutaneous sacral nerve stimulation. This is only after discussion in the local or regional MDT. If their symptoms have not responded to Botox, and if they're not prepared to accept, the risks of needing catheterization associated with Botox, then we go for the next treatment, which is sacral nerve stimulation. It involves applying an electric current to one of the sacral nerves via an electrode placed through the corresponding sacral foramen. The electrode leads are attached to an implantable pulse generator, which stimulates nerves associated with the lower urinary tract. So this is how the picture, as I explained, this is the electrode, which kind of is implanted there, and it kind of stimulates the sacral nerves. In our unit, some of the urologists do it. We as gynecologists haven't done it as yet. Surgical management of stress urinary incontinence. The most popular at present in UK is the mid-urethral bulking agent called Bulkamid. The reason for this is all the invasive procedures like TVT, TOT, they've all been banned in UK, so we can't do any of those. Although there have been wonderful operations, a group of women suffered, and hence, as a result, we cannot do them here. So Bulkamid is the first thing we give as an invasive treatment, wherein urethra is bulked. I will explain that in detail. The further surgical managements are corpus suspension. So if Bulkamid fails, then we go for corpus suspension. The procedures done less frequently are autologous rectus facial sling, transvaginal laser therapy, mid-urethral mesh sling procedures, and artificial urinary sphincters. So Bulkamid urethral system, this is a system which has got the little urethroskop. This is the urethroskop, which is about I think it's about 6 centimeters altogether, like a little scale, small scale size. And as female urethra is only 4 centimeters long, this whole thing goes into the urethra. This is the injection which has got the bulking agent in it. And you have this blue inlet and the red outlet, which kind of fills water while we do the urethral bulking. And that's how it is held. So the idea is that injection goes to the mid-urethra. So your view on the urethroscope will be this, where you can, these are the ports where the needle comes, that's the needle tip coming in. And we inject in 3 sites like that. The recent advice is to inject in 4 sites, wherein take this as a square and give 2 on the top and 2 on the bottom. Earlier, when we started, we used to give 2 on the top and give 1 at the bottom. So Bulkamid in itself, it's a urethral bulking agent, which is polyacrylamide gel, which is like a dextran gel. It's a treatment option for women with stress urinary incontinence. The efficacy of this treatment modality is variable in the current literature, and repeat injections are often required. This bulking agent appears to have no serious adverse side effects, and it is NICE approved. The next procedure, as I explained, is called suspension. I think this is the gold standard for stress urinary incontinence, and most of us from the older generation have done this procedure in the past. I think it is coming back again as we have no mesh procedures in UK. So colpus suspension is an operation which uses stitches to support the bladder neck so that it can't move about and cause stress incontinence. So if you see in this picture, I've made a little where this is the urethra, and you're taking the stitches from behind to the pubic bone. The downsides of colpus suspension, it is a major surgery, obviously, so you need time off from work, and you have to need time for recovering. And it's got all its associated risks like bleeding, infection, and needing a general anesthetic and all this associated. Sometimes girls can develop a difficulty to empty bladder post-operatively as we shift the bladder neck, and it can kink, and difficulty of mixed urination is a real problem. People can develop de novo or new overactive bladder symptoms after colpus suspension. And as we tie up one part of the bladder neck up, there's a risk that other parts of the vaginal wall can prolapse, and that is a risk as well. And some women even develop pain during intercourse. Looking to the future, transvaginal tape procedures may come back with stringent guidance in future, at least in UK, that is what we are hoping for. Mesh procedures may be only done in selected centers to keep the complication rate down. This is what we're looking for. The new guy on the block is a transvaginal laser therapy. In this procedure, a device containing a laser is inserted into the vagina, and the laser heats the tissue of the vaginal wall, causing changes to its structure. It is thought that this could improve support to the bladder. This is how the apparatus looks, and I am yet to be convinced that this is going to be what we'll need in future. Being a woman, I think differently. It's predominantly done by men. The device is produced by men. So we have to be convinced that this is what we need to look in future. But this is coming up. Hopefully in future, we will find something like this is more useful. So the evidence on transvaginal laser therapy for stress urinary incontinence does not show any short-term safety concerns. Evidence on long-term safety and efficacy is inadequate in quality and quantity before we can recommend. Therefore, this procedure should only be used in the context of research. I think that brings the end to my talk. I'm happy to take any questions.
We were listening your mesmerizing talk like anything, and just couldn't just imagine that it's going to end. Dr. Uma, it was very well, I think, nice, and all the chairpersons can comment. And this laser one, and that I think I missed your comment on vaccine also. This in India, I think that many people are doing this laser one.
Oh, okay. We in the UK, we have such stringent rules for everything. So yes, it has not been NICE accepted. NICE is our National Institute of Clinical Excellence. They have to accept for us to do anything. Otherwise, my GMC registration will be under complete problem. So we don't do that as yet. What is your experience with that?
I don't know. I'm least convinced because those who are doing, they are claiming a very high and very good results, and they say ki this is something unbelievable technique and giving so much of helping and all this thing really working. But as such, I have no experience, and that's why those who are doing, because aesthetic surgeons and all, they are and not proper urogynecologists are doing, I think. But somehow the gynecologists have taken it up.
What does that tell you? It tells you that urogynecologists are not convinced. Now, in this country, it's predominantly Egyptian men. I'm not being judgmental, but it's predominantly Egyptian men who do it. And the person who advertises is men, and I'm just still not convinced.
Okay.
Dr. Uma, as a chairperson, I'm Dr. Rekha Rajendra Kumar here. I had one or two small doubts. I will not take much time of anybody here, Madam, Archana Madam. My first question would be, how far you're convinced with the Kegel's exercise in preventing the surgery in any kind of incontinence? Does it really matter? Because we tell the patient every time that would be the first line of treatment.
Yeah. Our RCOG says, the Royal College guidance says, anywhere between 20 to 92% of patients will benefit with physiotherapy. But this is something the patient has to get convinced that, because it is not like you do it 2 times and you get better. It's religiously you do it, 20 minutes every day you do it. And so if our colleagues, friends, people, colleagues' wives come and ask, this is what I tell them: do it all the time. As and when you can do it, you do it.
Yes.
So I'm a big believer in physiotherapy.
Yes, I agree. I'm also one of the chairpersons. Dr. Uma, that is one place where our Indian population, because having worked in UK and here, the one difference is probably in our busy OPDs, we don't find time for 2 things which could help a lot. One is, counseling them about Kegel's exercises right from the time of first delivery. So I think our postnatal physiotherapy lacks, and that reflects in the postmenopausal phase in the form of incontinence. So I think there is a need for us gynecologists in India to strengthen our, post-delivery physiotherapy. Secondly, I think we use bladder diary very less often, because I have found that if we can request them to maintain a chart of what they're drinking, when they're leaking,
that will be helpful.
It really helps, so we can pick up where to, curb it. And
correct,
because in our, very few urogynecologists are there, and things like laser and corpus suspension are not so, what do you say, Dr. Archana? Not so
Yes, exactly. Because in our time, when we were house officers and PG, we were seriously doing it. Until now, my first thing is to squeeze out, to do the Kegel exercises, because this thing is really, really very helpful. Nowadays, actually, we don't have time, and we jump straight away to all the medications and go even for a long way to Botox also.
Absolutely. And I think progressively obesity is also becoming so common. So, making them control their weight is challenging. And Dr. Uma, you said smoking in India so far is not a problem. I think in our setup,
in rural, Neera, actually smoking is such a different thing. In rural, everybody used to do that BD system.
Bilkul. And even in our, population, in the well-off people in our NCR, I think so many women are smoking. It's just that you have to take their history of smoking and alcohol. So India has changed now. And I think that history is also quite important.
Yes. Relevant,
this is a female anatomy, and the female hormones. They really play their role, and stress incontinence or any sort of incontinence is so much common. Even I think a little bit of 10% to 20% incontinence has to be there after delivery. I think even somehow the cesarean patient, they experience less, but somehow they do also. And that this incontinence is really, really as common as a woman crying and weeping and tears coming out.
Yeah. And Dr. Uma, this Palshetkar, you are injecting or the urologists are injecting? Because I haven't seen.
No, we do it. We do it. In fact, I train a lot of people doing it. I had done a workshop is it AICOG? I had come and presented it, I think, before COVID, and we went to some private setups and we demonstrated. In Indian currency, it costs about 50,000 rupees, but for a woman, it's life-changing. A silk sari worth 50,000 rupees, isn't it?
Yeah.
So what's
So,
the efficacy?
So difficult socially to manage yourself when there is especially large volume of stress incontinence. It's so socially debilitating.
It is, yeah.
Is it easily
the
available?
one thing which I didn't, sorry,
is it easily available, this bulking agent?
in India, it's supposed to be getting approval as in because it's like as a device, not like as a medication. In UK, it's like a medication rather than a device. So the approval is slightly different there. So that's where they were looking at. This was about 3-4 years ago. The one thing which I didn't mention in my talk, and as we were talking about hormones, menopausal women, we sometimes give vaginal estrogens, and that also helps in some amount of incontinence. And the older women, that's one of the modalities we treat them with, which is Vagifem, which comes in a pellet form, and we ask them to insert it in the vagina like daily for 2 weeks and then twice weekly thereafter for up to 3 months. So sometimes vaginal estrogens also help.
Yes. What I think, Dr. Neera, this topic is really something really need to be discussed again and again, because looking at it and the experts we have, I think very soon we will be arranging another, and hopefully physical.
And we will be
will be my pleasure. Will be my pleasure, yeah.
Yes.
Thank you so much for your lucid talk, so much knowledge you have shared, your experience. We are really indebted.
Oh, my pleasure. Thank you.
Just to add on to one of my experiences, I think in India, diabetes is very, very important screening test for women with polyuria. I mean, I can't say nocturia as well as, daytime frequency, because I recently had a patient who was operated a couple of years ago for stress urinary incontinence, and she had a midurethral tape 5 years ago, and she presented with extreme, incontinence. And we initially thought it was just, it was a failure of the tape. They didn't do it well or whatever. But finally, when we investigated her sugars were really high. And then when we controlled the sugars, actually, we thought we were requiring another procedure, in fact. So that she was that bad. And then when we corrected the sugars, she improved dramatically. So I think a lot of medical causes, also people on antihypertensive drugs, sometimes they are on diuretics, and coffee and tea. When you go into the urinary diary, you definitely see Indian women, especially housewives, they take 5 coffees a day, is something very
such a lovely coffee too. Such a lovely Indian coffee.
Yeah. And
so having stress incontinence is
a discussion, I should say.
Of coffee. That's what you say.
No, mentioning about diabetes, when we used to do the transvaginal tape procedures, we used to distinctly remove the women who have got diabetes. We wouldn't ever put a mesh for them because the risk of infection. And if it's once infected, that's it. It'll wreck for life. You can't do very much. So you're quite right pointing out that, diabetes is the cause.
I've had many, many patients coming with, urge incontinence, and many of them are diabetic, sometimes autonomic dysfunction. So that's the crux of the problem. And you go and operate, and then you're in trouble. Yeah.
It's the combination of,
indeed.
Yeah, it's the combination of neuropathy as well as the detrusor irritability.
Excellent presentation. So now should we move for the next one, Dr. Reenu?
Thank you.
Definitely. Thank you for the opportunity, Dr. Archana and Dr. Deepa. Thank you so much.
Dr.
Actually, incontinence is a very, very wide topic. I think that was very well dealt with by Dr. Uma. It's a huge topic in itself. So thank you so much for your time, Dr. Uma. I think it's a great pleasure for me to welcome our next eminent speaker, Dr. Manjula Annappa, joining us again from Stoke-on-Trent, UK. She is, again, a beauty with brains, I should say, very smart young doctor. I've heard her a couple of times, and she's joining again after an emergency surgery just to be with us today. So thank you so much, Dr. Manjula. Thanks for being here today. I request the chairpersons, Dr. Alka Sethi, to take over the chair. Thank you.
Thank you. For inviting all. And today we have so many beautiful South Indian beauties. Dr. Krishna, my darling, Dr. Deepa.
Love you too.
Manjula Rekha was here from Bangalore. I think बहुत अच्छा आज today. मतलब इतना representation is so good from Trichy, from Kerala, from everywhere, and UK especially.
Dr. Manjula is from Karnataka. Her roots are from Karnataka. I think she's migrated.
Okay.
Now,
welcome, Dr. Manjula.
Second talk, I'm inviting chairperson of the second talk, Prolapse and its management, Dr. Alka Sethi. She is secretary, Jhansi, president, IMA Jhansi, gold medalist, city coordinator, food and drug medico-surgical committee and adolescent health committee. Welcome, Dr. Alka Sethi.
Thank you. Ma'am, I think because we're chairpersons, short of time, you can just play my thing. I think we can go on to the speakers immediately. Alka ma'am, on to you.
Yes, I would like to introduce a very dynamic, beautiful, as already compliments have been given to Dr. Manjula. She is a consultant urogynecologist, University Hospital of North Midland, Royal Stroke Hospital. She was a consultant gynecologist, Diana Princess of Wales Hospital in 2020. Her main field of interest is urogynecology and pelvic floor disorders. She's been invited as a guest speaker in so many conferences and was international faculty in urogynecology and chair at RCOG World Congress in 2014. There are so many accolades to her credit, as we can read. I think I invite you, madam, to please enlighten us about a very important topic, and we are all waiting to hear to you. Dr. Manjula, please. Thank you.
Thank you so much. Very overwhelmed with all the seeing all of you. And I thank Alka as well as Archana and Deepa to give me an opportunity to be here. I also have to thank Uma, my colleague. It's a working day within just a busy schedule. She has agreed to do the incontinence, which was an excellent talk. Also, thank you for accommodating our request that we wanted to join at around between 1 to 2 UK time. So moving forward, I'm going to talk on prolapse. Apologies, I don't have the control now. So I have to request to press the next. So I have no disclosures. You have got this section, which is on the question and answer or in the chat. Can I please request the participants to just type what do they feel about this prolapse? What is it? What kind of prolapse is this, please? Just a few minutes. If you can just type, it'll be interesting to know what will be the interpretation of different gynecologists for this prolapse. Yeah, I can see this. Few writing prosidentia, complete prolapse. Yeah, good. So this is a lady who actually came to see us. She is a 64-year-old, BMI of 33. She has just had one normal delivery. So no other surgical history in the past before she came to see us like 4 years back with prolapse, and she had huge prosidentia at that time. So she had a vaginal hysterectomy, anterior repair, posterior repair, and sacrospinous fixation, because she was sexually active and she didn't wanted any mesh. 6 months after that procedure, she came back with a huge prolapse again because it was a huge prosidentia and she had massive vault prolapse. So at this point, as she already had sacrospinous fixation, so we did a sacrocolpopexy, which was a mesh attachment. She was fine, so we didn't get to see her for a year. After a year later, she just came back, and this is how she's come back. Does that change your decision? We have done the sacrocolpopexy, we have removed the uterus, we have done the sacrospinous fixation. So what is this prolapse? Does anybody want to type different now?
Wall prolapse.
So on the top, yeah. At the top, actually, if you can see, it looks like a urethra, but there is just a skin fold. That is the vault. But the rest of it, below that, is completely enterocele. It's a huge enterocele. where she had the whole bowels you can easily palpate, all the gurgling feeling you can appreciate. Her symptom was just a prolapse. So with this massive prolapse, you would expect that she would have bowel or bladder symptoms, but she denied any voiding problems. She denied any problems of opening her bowels. And she said, it is just this prolapse where I find little difficulty sitting, but otherwise it is not stopping me from doing any other activities. It's kind of a size of fetal head. So she already had mesh. I think she also had mesh rectopexy, which is for her rectal prolapse by colorectal surgeon. So it was very challenging. And even reducing this prolapse was not possible because it was so edematous. So we have to actually take her to theater under general anesthesia. We have to reduce the prolapse, pack it daily so that we can improve the quality of the vaginal skin with estrogen cream. And then decision was just to do a massive posterior, huge rectoenterocele repair with McCall's scaldoplasty. That was the plan. But then, as you can see, how huge prolapse is, her urethra was kinked and she had massive hydrouretral hydronephrosis. And she became very poorly because of renal failure and she never made it to surgery. That is this patient. Can I move on to the next slide, please? So the statistics I'm presenting in the UK, I'm so sorry, I don't have the Indian statistics, but we have at least for every prolapse and incontinence where my colleague Uma presented, 2:1 ratio when we have to operate. So most of them can come with combined symptoms of bladder as well as prolapse. We have the statistics, which is between the reproductive age group, like 30 to 60, menopausal age group, the prevalence is around 30%. And majority of our waiting list are with the prolapse surgery or incontinence surgery, which makes up to 20%. Whenever we counsel the patients, we always tell them that the first surgery has got the best success rate, but recurrence rate is high and reoperation rate is high, and that is 30%. I think this stands for the world statistics that there is a recurrence rate of 30 to 40. Just little small understanding that this is how our teachers have taught us that it's not that it's the organ that is the problem. It's not the uterus, it's not the bladder, it's not the bowel. It's basically these three organs are actually the boat. And if we actually analyze it like how the boat and what are the things that supports, the water is the levator muscles, and the moorings are the endopelvic fascial ligaments, the huge endopelvic fascia, which is, we read it as urogenital diaphragm. So these levator muscle are in the fascial ligaments actually holds the organs in place. So if there is any problem in the levator muscles or the fascial ligaments, which we all know happens so much of stretching during childbirth. So obviously the result of that is sinking of the boat, which is the organs. So the boat itself is actually fine. That is how I usually teach to the medical students. Next slide, please. I'm sure you're all aware of anterior compartment, central compartment, and posterior compartmental prolapse. Next slide, please. So this is the central, where we have seen that the cervix or the uterine descent, and if you have removed the uterus or the cervix, then we call it as top of the vagina, which is called vault. That's the central compartmental prolapse. Next slide, please. Or you have anterior or posterior compartment where anterior vaginal wall comes, it's a cystocele. Rarely we do actually talk about urethrocoele, but it's not much that it's mainly cystocele. And also posterior compartment, we do see more of rectocele and yes, next slide, please. If it is the lower 1/3, then it is rectocele, but above that, we actually say it as enterocele. I think it is important to know whether it is a rectocele, enterocele, or cystocele, and how much are we going to operate, how much are we going to reduce, which will come to later part of surgical intervention. I think this has been a Urogynae sessions. Most of the presenters have gone through the slides. We all know the etiology or pathogenesis, which I don't want to repeat it again. The only thing I would like to mention here is lifestyle modifications, when we say, there are so many certain things that we can pick up that's causing or contributing to prolapse or to the bladder symptoms. One is smoking, which is actually increasing recently I can see that the changes every time I come in the urban population as well. And of course, we all love takeaways. We all love fast food chains. We are all eating outside more than that we used to do at home. And we love our fizzy drinks. Can't manage without Coke, without nice milkshakes. So that has led us to have obesity. So having an obesity, having this factor can actually contribute to the prolapse or leaking of urine, and also occupation. Again, when I counsel the patients, I do ask them that what is their occupation. And of course, we cannot say that you have to stop what you're doing, but maybe how we counsel and how they can redistribute their work. For example, if you have a dai or a maid who is actually looks after little children at home, or a nanny, she has to lift that child, and lifting that child itself is enough weight, like probably 5-6 kilos, or depends what the weight of the child and age of the child. That itself is a precipitating factor. So you need to be a little careful when you counsel. Or somebody who works in a factory where it involves lifting very heavy goods, like lots of objects in it. So then I say, like, try to redistribute it, do it in a small quantity, because even if you operate again, there is always a recurrence of prolapse. So lifestyle modification is so important. The collagen disorders, again, I would like to mention here, we do have few patients who have got Ehlers-Danlos syndrome. You operate on them, but recurrence rate is very high. And even if they do pelvic floor exercises, again, it might not be as successful. So again, you need to counsel that, yes, we do, but your recurrence rate may be more than compared to other population. The next step, please. The patients can present to different consultant specialties. So either they can come to gynecologist because they have got this notice, the bulge, or they can go to urologist because they just think that they have got a bladder symptoms, or they can also go to our surgeons, colorectal surgeons, mainly complaining of difficulty evacuating, or what we call as obstructive defecation symptoms, where they say that they have to introduce their fingers into the vagina, or they say that there's a skin between the front and the back opening. That's the perineum. So this is important, because if they're saying that they have to actually do this method, and that has led to prolapse, because one of the reason is constipation. So please address, when you're talking about lifestyle modification and when you're actually taking the history, it is important to ask what is their bladder habit and what is their bowel habits. And there is a constipation that needs to be addressed. Fluid and fibers necessarily might not cure the problem. So you do put them on lactulose and fibergel bowel softeners. And it is okay to be on long-term bowel softeners or laxatives to help them open their bowels. Because when they're straining, obviously they are actually putting so much pressure on their pelvic area. So as a result, they are going to have the prolapse. The other thing I want to stress is obstructive defecation symptoms. If you have a patient where you have noticed that they've got a rectocele, and they say that they have to digitalize into the vagina, then maybe if you correct rectocele, even though we have done a study where we did a rectocele repair, those who had obstructive defecation in the vaginal area, or those who are actually pressurizing on the perineal area, operated posterior repair, and the ones who said that they had in the vaginal area, their symptoms got cured. But those who are actually digitalizing over the perineum, no matter what you do, it's not going to help. So it is important to counsel and find out what exactly are their symptoms. The other complaints could be varying. It could be just they have come for incontinence or difficulty voiding, especially if they have got cystocele. And then when you examine, you find that there is a prolapse, or it could be that they have come because they're having difficulty with intercourse, and then you find that there is prolapse. So the variation of presentation is very vast, and it can be between gynecologist, majority will be, but it can go to urologist or our colorectal team. And hence our multidisciplinary team discussion, we have all this team where we say, like, okay, I have seen her, like colorectal will say, we're going to send you to the gynecologist for examination and so forth. We also send them if there is obstructive defecation symptoms, and especially over the perineum, majority will have rectal intersusception. So your posterior repair is not going to cure. So please pass it on to your bowel surgeons or colorectal surgeons. The next slide, please. Again, I have mentioned about different symptoms which are all aware. We will go to the next slide. Sexual problems, it is very important, especially in the Western culture. They do talk more about it, which is probably not much forthcoming in probably Indian population. One thing that I have learned, I'm sure Uma, my colleague, also will agree with my decision that whenever they come for prolapse symptoms or for bladder symptoms, we do give them a questionnaire to fill. I do actually encourage my all these participants today, please go on IUGA, International Urogynaecological Association website, or even if you Google and put ICIQ, it is an International Continence Symptom Questionnaire for urinary problem and also for the Vaginal Symptom Questionnaire, which is freely available. It is also available in different languages because IUGA has been working on it, and I encourage that if it is not there in Hindi, probably it is there, if not, or in the local languages, please try and get your trainees or someone to do it, which looks good on CV. So whenever the patient comes before to see us, we actually ask them to fill that questionnaire, which will has got vaginal symptoms, which will say like there is a grading. Do you feel the bulge? Do you feel the bulge? It is outside. How much does it affect on the scale of 0 to 10? Do you have to, press on the vagina to empty your bowels? And also there are questions about sexual symptoms. Is your sexual symptoms, or do you have a sex life first? Second is, do you have sex life problems because of your prolapse, or is it due to other reasons? At the end of it, they give it to us when they have filled it, and you have got a scoring for that. And when you score, Uma, I think you agree now, those who score more on the sexual symptoms compared to their vaginal symptoms, in our studies, it has shown that their expectation from whatever intervention that you're going to do is very high. No matter what you do Pessary insertion or you do surgery, they are never happy. And also, please be mindful that especially if they're scoring so high or if they're sexually active, please do not correct both anterior compartment and posterior compartment at the same time, because it's going to narrow the vaginal introitus. It is going to cause constriction ring because vagina is like a cylindrical structure. So when you do both anterior and posterior repair, you can examine and see how the constriction ring is formed. And that can cause very difficult, especially dyspareunia. So they may not be coming forward, but please do ask about, do they have a sexual activity? And if that is the case, please, it depends what surgery and what type of pessary you're going to choose. Next slide, please. Other symptoms, I think majority do come. I remember when I was doing in India, post-graduation, just discharge, chronic discharge, or bleeding because of the decubitus ulcers, or low backache. They don't say that there's prolapse, but they come like there's a low backache constant and it worsens at the end of the day. And when you examine, there is a prolapse. And skin irritation, mainly if they have combination of prolapse and incontinence, there can be quite extensive skin excoriation. So barrier cream or emollient cream is very important when you actually see them and prescribe. Next slide. Okay, how do we approach? Apart from actually giving the symptom questionnaire and taking the history, examination is very important, and you all agree this is the SIM speculum, which is the best way to actually assess the prolapse. If they are on the lithotomy position, it is very slightly different, especially if they are in the left lateral position with the SIM speculum. You can clearly demonstrate the anterior compartment, central compartment, and the posterior compartment. We do have combined clinics. Sometimes if there are very complex cases, we do clinics with the colorectal team or the urologist, and we also do surgeries together. Next slide, please. This is very important. because you were all asking about pelvic floor exercises. Again, it is the standard treatment, especially if they have got grade 1, grade 2 prolapse. And if they are in the age group where they are between 20 to 60, we still send them for pelvic floor exercises. And also, there's online available, you can just Google pelvic floor exercises. We do tell them patients that please Google yourself and you can find out there are different types of Kegels exercises. There are also pelvic trainers, which they can buy from Amazon, which are quite effective, especially these days. Everybody is aware, everybody do go to gym, Zumba. So why not even pelvic floor exercise be a routine part of their day-to-day lifestyle. Next is standard, we do give estrogen cream because there is atrophic vagina, and average age of menopause in UK is 50-51, but Indian population can be quite earlier than that, probably around 45. So even though they have their periods, you can still prescribe estrogen cream. It is safe to use. It's a very, very low dose local estrogen cream. It improves the quality of the vaginal skin. It reduces the friction if you're inserting pessary, or it helps your surgical dissection if you're going for surgery. Lifestyle modification, which I told you about, working, smoking, constipation management, chronic cough patients, please, if they have got COPD or apnea problems, please ask your medical colleagues to see that that is sorted, because even though you do any surgery, if they keep coughing, it can just reoccur. Pessaries, we have got a huge waiting list. Probably the waiting period before they come in to have the surgery is up to 6 months to 8 months, and more so with the COVID, it is prolonged. So we do actually offer them pessaries. Next slide, please. There are different types of pessaries. The top one, ring, is very commonest. We all have seen this. That pessary, ring one, is used for those who are sexually active. And we do tell them they can have intercourse with this one. And this pessary needs changing every 6 months. Please use the estrogen cream or the vaginal moisturizer, because it is easy to insert or take it out. And if they don't use anything, it's going to be really very foul-smelling discharge. Sometimes they do bleed because of the friction. The other types of pessaries we use is on the left side, you can see shards. The other one, most popular we use, is down, which is Gellhorn. It's really soft, malleable, which we can insert. And the shelf pessary. The ones with the handles, which is at the bottom, Gellhorn or shelf, as you can see, they have handles. They are only for those who have who are not sexually active. And rings are better ones for grade 1, 2, or 3 prolapse, more so for anterior compartment, which is cystocele. Any of the pessaries are not so successful, especially if you have a rectocele or enterocele. Again, for the central compartment, for the uterine or the vault, uterocervical or the vault, again, you can use the ring if it is grade 3. Again, grade 4, unlikely to work. Gellhorn or shelf pessaries are quite good ones. They are actually more supportive for if you have a massive vault prolapse. And next slide, please. This is how the Gellhorn pessary looks like. Let's it's in. Next slide. So when we actually insert the pessary, it is we do counsel them getting the right size. Sometimes can be a trial and error. So occasionally they might need 1 or 2 fittings. It might fall out. Counsel them, give them the number to contact. If it falls out, it can happen. You may not get the right size, so you may have another appointment to again fit in slightly smaller or larger one. Smaller if it is too uncomfortable, and the larger if it falls out. This is for the Gellhorn. For the Gellhorn pessary, as you can see, the patient is lying left. This is actually a lateral view. So if you insert the fingers into posterior fornix, that is your middle finger, and then as you can see, the thumb is just over the pubic symphysis. The length from the posterior fornix to the pubic symphysis, that's the linear length, that is actually the size of the Gellhorn pessary transverse. So we say it like size 8, which means it is 8 from posterior fornix to the pubic symphysis, that is the length. Or we say size 10, size 12. With the ring pessary, it is slightly different. Next slide, please. Oh, I think we missed a slide there. So with the ring pessary, can we go back, Deepa? Back again. Back. Oh, sorry. I think that slide is gone. With the ring pessary, just put the fingers into the vaginal fornix and just extend from both lateral fornixes as far as you can. And this is the length. That's the diameter of the ring. We say it like it's like 50 millimeters or 60 millimeters. That means it's the 6.8 centimeters. So that is for the ring pessary. But for the Gellhorn or shelf pessaries, this is actually in the posterior fornix, and that's the pubic symphysis where it is touching. So it is the length from the posterior fornix to the pubic symphysis. So once we insert the pessary, we give them the number to ring. We ask them to use the estrogen cream. Twice weekly is enough. And ring pessary can be changed every 6 months, but if we use other supportive pessaries, we change every 4 months. Next slide, please. Failed conservative management, or if it's the grade of prolapse is 3 or above, we go for surgery. Again, we discuss the cases in the team where there is Urogynae, urologist, physiotherapist, give their assessment, and then we put them for surgery. Next paragraph. Sorry, next slide. So there are different surgeries which I will not go through. I'm sure you're all familiar. This is the first surgery gynecological that I learned when I was doing post-graduation. So there's plenty of them: anterior, posterior repair, vaginal hysterectomy. Again, we did more Manchester repairs there in India, I should say, compared to UK. We do sacrospinal fixation. Sacrocolpopexy was very common, but however, due to the mesh litigations and mesh related controversies, we have been very careful. So we don't do much, but if they have had all sacrospinous fixation and that's failed, then we actually post them for sacrocolpopexy. Colpoclysis, again, those who are not sexually active, very old, frail, we do them. I think that's one of the best operation I say for colpoclysis. Some of the challenges for surgical repair, I've just only got it is, as I said, mentioned, please look at the scoring if there is a feasibility for that. Sexual symptom scoring more than vaginal symptom, they are never happy. Also, don't do surgeries if it is just grade 1 or grade 2. So it should be 3 or above. And repeat surgeries, especially with anterior posterior repair, again, the scoring is so much, you may not achieve enough reduction of the prolapse as much you can. So counseling is important. And sometimes if you have a combination of rectal prolapse and vaginal prolapse, you can operate alongside with the colorectal team. Next slide, please. Just quickly, I'm not going to go too much into depth. The cystocele or rectocele and all add 20 ml of that with 20 ml of normal saline to have a good infiltration into the vaginal walls that you are going to actually correct, either anterior, posterior, or into the cervix if you're doing hysterectomy. Again, McIndoe scissors, I find it very useful, especially if we are doing the vaginal wall epithelium peeling for colpoclysis or anterior posterior repair. We use PDS for plications of the rectovaginal fascia or the pubovesicocervical fascia when you're reducing anterior or posterior repair. And please, when you have done the plication of the fascia, always the vaginal skin, we do the trimming. Please be mindful that, especially when you're trimming the vaginal skin, try not to take too much of it. That is what causes the constriction ring and also causes dyspareunia. So, and also, as I said, mentioned, it's curvilinear. It's cylindrical, the vagina is. So try not to cut straight into the vaginal skin. Try to cut it as inverted C shape or curvilinear so that in the center, there's no constriction ring. Next slide, please. Some of the tips, we use this self-retaining retractor, which is very good with the clips. It's called Star or Star retractor. Again, I think it's available in UK as well. I've asked, in India. I've had a discussion with a few other colleagues. It's really good. You don't need an assistant as well. Posterior bleeds more, posterior compartment bleeds more than the anterior compartment. So especially there is 2 veins just as you open the vaginal skin near the forehead. Please actually cauterize them before you proceed so that the bleeding in the posterior compartment is less. Next slide, please. That's what I've just mentioned. Grade 1, grade 2, please do not offer surgery. Obstructive defecation patients who are actually digitalizing over the perineum, no matter your whatever you do, prolapse surgery is not going to cure. Those who have combined compartmental prolapse like anterior or posterior, and if they're sexually active, try not to do both together. Do the one that is predominant. For example, if it is grade 3 cystocele, grade 3 rectocele, again, you have to counsel them. We will do it, but there could be constriction ring. We try not to, but everybody heals differently. Or if they have got bladder symptoms, predominantly with cystocele, I would rather do that than doing the rectocele and address the constipation. Do not excise too much of vaginal skin, and do not plicate the levator ani muscles. I'm sorry, I have to mention this. When you do posterior perineal refi, that is only for the deficient perineum. That is not to correct your rectocele. So putting a tight stitch around the levator ani muscle will only cause so much of discomfort when she's sitting or when she's walking or for dyspareunia. All the treatment or the surgery should be for the endopelvic fascia and not into the levator ani muscles. The plication of levator ani muscles is only for very, very deficient perineum and not for the rectocele, enterocele, or cystocele or uterovaginal prolapse. Next slide, please. When we operate, we do it as a day case. If it's done in the morning, they go home later in the evening or next day. We put a Foley's catheter and pack for 4 to 6 hours, vaginal pack, which is removed, and then we give analgesics, which is simple paracetamol, ibuprofen. We try to avoid codeine because we do not want them to have constipation post-operatively. We do give them standard is laxatives for first 4 weeks. All of them will go home with lactulose 10 ml BD and Fibogel 1 sachet BD for 4 weeks. We give them the information leaflet about pelvic floor exercises, which they can resume 3 to 4 weeks after the prolapse surgery. All of them get anticoagulation for 7 days and stockings to be for 4 weeks to reduce any risk of thrombosis. More so, this should be a standard practice, especially with the COVID. There's always a risk of thrombosis, even in the asymptomatics. So please make this as a standard thing at your side as well. We arrange them to have a follow-up virtual clinic, which is a telephonic. Only if they have any problems, then we see them. Otherwise, usually the clinics are 3 months post-surgery. At that point, again, we post them the symptom questionnaire so we know what is the scoring before the prolapse and what is the scoring after they have actually had the surgery, which will tell us the success of the surgery as well. And it is mandatory for us as a urogynecologist when we do any surgical procedures for prolapse or incontinence, we have to add their database onto the National Surgical Database. Next slide. That's it. Mesh, again, be very careful if you're using mesh, counsel them, especially if they are sexually active. Estrogen should be lifelong if they've had the mesh so that there is no mesh erosion. Next slide, please. Prevention of recurrent prolapse, please. I actually stress lifestyle modifications, exercises. Yoga has been such a popular thing. Yoga does help with the incontinence, with the overactive bladder, and even with the prolapse. So again, I think it was Dr. Neera who mentioned about prevention is better than cure. We all know childbirth is the first culprit to have any pelvic floor problems. So if we can educate them during antenatal classes about pelvic floor exercises and to resume those pelvic floor exercises as soon as they had delivery within 2 weeks and to become as a routine for lifelong, everyday practice. Next slide. So that's it. Not sure we can still hold up everything when we hit 65, 70, despite all the interventions. Thank you very much. Thanks for the opportunity.
Thank you, Dr. Manjula. That was a very concise and very precise. I would say that was very, very, it was very illuminating. I think there are a lot of questions for you regarding the questionnaire. So if you could just post a site in which the questionnaire, the standard questionnaires can be given, I think that would be really appreciated. But apart from that, I think your I think which has to be tailor-made for everyone. I think that was very illuminating the way you pointed it out. So thank you so much. And I know it's your break time there in the UK. So thank you so much for joining us. And it was a wonderful session. Any other questions? Yeah, I just think you have a lot of accolades. Thank you so much. And have a wonderful day. Thank you so much.
Thank you.
And ma'am, thank you so much for the opportunity. Avi ma'am and Reena ma'am, thank you so much. Bye.
Krishna, thank you so much. And thank you, Dr. Manjula. I think it was one of the most wonderful, really to the point, and so many tips, and are talking about the boats, sinking the boat. I really like this explanation, and easy language, no confusion anywhere. I think to be even all the vocabulary and all that this thing, I think at least I really need to learn all this, because in all my PPTs I put so many images and so many things. People get confused, and to talk less and to so that things are very clear is something very, very important. And you did the justice to the topic.
And I think especially your last cartoon kind of summed it up. No matter how much you do it, age, I think it's a wonderful factor. No, ma'am, I think that was a beautiful thing.
Can I ask one question from Dr. Manjula, if time permits? Dr. Manjula, if you have a case of prosidentia, see, you've done the vaginal hysterectomy. I tend to do a laparoscopic colposcopexy, but you said mesh is going in out of repute. So what would you operate in this sort of a case? How would you manage?
With if it is a primary procedure with the huge prosidentia, one is, of course, we do actually offer mesh, but again, if they are sexually active and if it is very important, then there is a risk of mesh erosion. So that's why we counsel them that that risk is there. Do you want to take it? Otherwise, what we do is actually hysterectomy with sacrospinous fixation. I know there is a 50% failure rate, but majority don't want the mesh, especially more so with this mesh litigation they have, and especially it's being in the public domain. Lots of them don't want, and if they've had primary surgery and they've come back, then we used to do like at least like 10 or 12 a year. Now it's only 1 or 2 a year, sacrocolpopexy. They don't want it because they're worried about chronic pelvic pain, because with the mesh, there's always chronic inflammation. And that's how the fibroblasts are going to act around the mesh area. And that is how it holds it. And that itself can stimulate chronic, pelvic discomfort and dyspareunia.
Yes, I agree. Mesh erosion, mesh infection, pain, these are the complications. But then doesn't the vault after vaginal hysterectomy keep, giving them still that fun sensation of fullness out there, because it's sort of inverted, whatever you may call.
One is that if there are like
vaginal hysterectomy, how do you support the vault?
Is it, how do we support just doing vaginal hysterectomy? Is that what you're asking, Karina?
Yeah, we get big prosidentias here.
Yes.
From rural areas with large prosidentias. So we've done a vaginal hysterectomy, but the vault is all everted. So we pick it up and, with the tackers, we take a Y-shaped mesh and fix it to the spine. So if that's not to be done, then how do we support the vault?
I think, Neera, we have to tailor our practice according to the places we are. I'll tell you why. One is UK is more like they all are more aware of the mesh and everything. And NHS is, Uma is around, I don't know, it's a free at the moment. Of course, from our salary, they do cut it, but we are not aware of it. So recurrent prolapse surgery, we can still do. But with the other side, like for you all my colleagues there, the one surgery they can only afford, they can't keep coming back, because it is going to be expensive. And with a huge prosidentia, I do agree that just doing a sacrospinous fixation, there's a very high risk of prolapse recurring. So yes, the mesh still plays a very good support to hold that huge vault what you're talking about. It is good, but we are being tied up by the guidelines that we have and the policies that has been placed due to the mesh litigation. Otherwise, mesh is a brilliant surgery, especially if there is a huge prosidentia. But again, important is lifestyle modifications, because that first slide that I told with the picture, she had a huge prolapse. We had done the sacrocolpopexy, but still it came back. One is BMI, chronic constipation. Once in a week, if they open their bowels, and especially with the tropical temperature, not maintaining well hydration and constipation and the diet can all play a role.
Dr. Manjula is recommending love your livators. So welcome, Dr. Nandita. Our chief guest has joined.
Thank you. Sorry, I was caught up. I was
Madam, still you have come. So we are very happy, and you please say a few words of your good wishes.
You don't need to play my CV. You don't need to play my CV. I was listening to Dr. Manjula, and it was really interesting what you were saying. Sorry, I need to go from here. Yeah, thank you. Sorry. Being a grandmother, I guess these are the pitfalls that you have to face. Sorry about that. But thank you, Archana, for inviting me here. I think it's a pleasure. And urogynecology is something that we don't discuss too much. We gynecologists are a little wary about it. And to have CMEs to make us more comfortable, I think that is very, very important. And I'm so glad that ISOPARB has taken, under your leadership, Archana, that these difficult topics of CME, I think it's very important that the gynecologists know how to deal with it, because quality of life is very important in a woman. And 1/3 of our lives are spent in, after 40 years, the longevity has increased. And these are the aspects that we gynecologists should learn how to handle them, how to tackle them, and how to advise them. I think this topic is fantastic. So once again, I congratulate your ISOPARB chapter for taking on these challenging themes as CMEs. And I was really enjoying listening to you, Manjula, when you were talking about the mesh. I think something comes in, and there's so much of, you and cry about it, and a good thing gets sidelined. So I think, yes, we may see a comeback, and let us wait and see for what happens next. And I would like to take this opportunity just to request all of y'all that I am contesting for FIGO representative election during 21st to 30th March. And I know you'll have all supported me always throughout my journey in FOGSI, and please do continue to do so. I would love to work on the international forum. I've worked on all the various national forums and worked on women's health policies. And I think working with the international forum with women's health policies is really a passion which I would like to pursue. So please do support me. Thank you. Thank you very much. Thank you, Renu. Thank you, Seema, for calling me. And I'm really indebted to all of you all. Thank you.
All the best.
Thank you. Thank you. Thank you.
All the best, Dr. Nandita. Thank you for coming, Dr.
With this, I think we can end this session and go to the next session. Thank you so much.
Going forward, now I am inviting third talk chairperson, Dr. Amrita Sarkari and Dr. Manisha Agarwal. Dr. Amrita Sarkari, she is consultant Obs and Gynae at Jaipuria Medical and Research Center and Garg Hospital, Gorakhpur. At present, she is president of Obs and Gynae Society, Gorakhpur. Dr. Manisha Agarwal, she is private practitioner in Ghaziabad and elected Secretary of Obs and Gynae Society, Ghaziabad, year 2022-23. Welcome, Dr. Amrita and Dr. Manisha. Now I invite Dr. Manisha to introduce our third speaker, Dr. Deepa.
Thank you, Renu. I have a pleasure to invite charming Dr. Deepika Mukandam. She is Secretary, Trichy Obs and Gynae Society and Executive Member of Midlife Management Committee and Tamil Nadu Obs and Gynae Society. Dr. Deepa is winner of Champion of FOGSI Award and President Rotating Trophy for Best Secretary in 2021. She has organized and delivered lectures and in various conferences
She has presented papers and authored various articles. She'll tell us about recurrent UTI. Welcome, Dr. Deepa.
Thank you so much, Chairpersons, for that kind introduction. First of all, my heartfelt thanks to Dr. Archana Verma for this opportunity, for involving me as a speaker in the midst of so many stalwarts. So thank you so much. Let me just start by sharing my screen. Is my screen visible?
Yes, Dr. Deepa, yes.
Slides are moving. Okay. The slides are moving?
Yes.
Okay. To talk about recurrent UTI in women, I think it's one of the most frustrating conditions, not only for the women, for also the gynecologist many a time. Because they keep coming back to you with issues. Looking at the scale of the problem statement, I would mean, UTI is one of the most common bacterial infections globally encountered by women. And the risk of a woman acquiring UTI in her lifetime has been estimated to be over 50%, with almost 25% having a recurrence in her lifetime, which is a huge burden. Recurrent UTIs are nothing but symptomatic infections that follow complete resolution of a previous UTI. And in a primary care setting, 53% of women above the age of 55 years and 36% of women, younger women, report a recurrence within 1 year. Let's just scale up our definitions. UTI can manifest as either cystitis when it is a lower UTI, or pyelonephritis when it is an upper UTI. And we need to differentiate between complicated and uncomplicated UTIs. Complicated UTI is one that is associated with a structural or a functional urinary tract abnormality or an underlying pathology, both of which can actually subsequently increase the risks of acquiring an infection, or they can contribute to failure of therapy. Uncomplicated UTI is one which is sporadic, community-acquired episodes of cystitis and pyelonephritis in otherwise healthy individuals, but this could lead to more serious outcomes as well, and we need to be careful in giving them also the required attention. Coming to the definition, recurrent urinary tract infections are more common in women and are frequently defined as 2 or more episodes in the last 6 months, or 3 or more episodes in the last 12 months. And we need to know what is a relapse versus a reinfection. A relapse UTI is one that is caused by the same bacterial strain implicated in a previous UTI within 2 weeks of completion of treatment for the original infection. And a recurrent UTI or reinfection is one that arises more than 2 weeks after treatment or after a sterile intervening culture, even if the infecting pathogen is the same as the original pathogen. Coming to the responsible uropathogens, we all know E. coli is the most notorious uropathogen, responsible for almost 70 to 95% of cases for both the sporadic as well as recurrent UTIs. The other causative organisms include Staphylococcus staphylococcus in 10 to 15% of cases, and also gram-negative organisms like Klebsiella, Proteus mirabilis, etc. Following the resolution of a UTI, small numbers of the original strain of uropathogens may persist in the host and lead to infection stones. This is especially with Proteus mirabilis, and one has to be aware of this. And although rare, it is important to know this, know that bacterial persistence is identified because it is the only surgically curable cause for recurrent UTIs. It has now been well established that there is a genetic and family history of background for recurrent UTIs. There is enough evidence to indicate that genetic involvement associated with an alteration in the patient's host response, which may be predisposing factor to some individuals in developing recurrent UTIs. And UTIs have been seen more prevalent in female relatives of women with recurrent UTIs, suggesting a familial genetic predisposition. So if you have a mother who has been having recurrent UTI, the daughter is definitely at a higher risk. Coming to the other risk factors for recurrent UTIs in women, we can categorize them in the premenopausal women and the postmenopausal women. In the etiological or risk factors can be very different in both. In the premenopausal women, a lot is a relation to sexual intercourse, especially recent intercourse, new sexual partners, multiple sexual partners, etc. The use of contraceptive methods, especially spermicides and dye from spermicide, is notorious. Previous antimicrobial use, estrogen deficiency in the perimenopausal period, strong genetic and family history, previous UTI, and a childhood history of UTI, especially if they are less than 15 years old. They are at higher risk, and the distance of urethra from the anus, non-secretor status of blood groups, and vitamin D deficiency, which can alter the immune response to any infection. These are the risk factors in the premenopausal women. And in the postmenopausal women, we all know that it is a state of estrogen deficiency, lack of estrogen, and urogenital atrophy is the culprit. Previous urogenital surgery, incontinence, cystocele, post-void residual urine indicating stasis, non-secretor status, and previous urinary tract infections are all risk factors. In the very elderly, above 70-year-old frail people who are institutionalized, procedures like catheterization and conditions like incontinence, urogenital surgery, diminished mental status, and poor hygiene and antimicrobial use are all risk factors. So the factors related to the pathogenesis of recurrent UTI can be either the virulence of the germ, or it can be something to do with the patient-host defenses. The germ can be a nephritogenic strain, and there are also the virulence is also contributed to by adhesion factors to the urothelium, especially the fimbriae. Patient-host defense mechanisms depend on urinary pH and urinary osmolarity, glycosaminoglycans that prevent bacterial adhesions, T and B lymphocyte responses, IgA responses, anti-reflux mechanisms, regular urination, and vaginal lactobacilli. So coming to evaluation of recurrent UTI in a woman with without any prior history of structural or functional abnormalities of the urinary tract presenting with 3 or more episodes in 12 months, a very good history is very important, particularly if she is young, her sexual history, her past history of any surgery, etc. And a good physical examination is very important. Simple tests like post-void residual urine measurement and uroflowmetry in postmenopausal women can guide us towards the etiological factors. A culture when the patient is symptomatic and 2 weeks later after completion of treatment with sensitivity adjusted antibiotics is also important to identify persistence or differentiate them from relapse. So if you find risk factors for complicated UTI, immediately it is an indication for cystoscopy and imaging techniques, and specialist referral may be indicated. If there are no risk factors, then we can treat them as uncomplicated recurrent UTI. So the indications for specialist referral are these: prior urinary tract surgery or trauma, gross hematuria even after resolution of infection, previous bladder or renal calculi, obstructive symptoms, which are very common in many patients, poor stream, hesitancy, voiding difficulty, weak stream and interrupted stream, low uroflowmetry, high pelviureteric reflux, etc. Urea splitting bacteria on culture like Proteus or Yersinia that can be associated with infection stones, bacterial persistence after sensitivity-based therapy where you have no clue what the etiological factor is, previous abdominal pelvic malignancy, diabetes and immunocompromised status, pneumaturia, fecaluria, anaerobic bacteria or a history of diverticulitis, and repeated pyelonephritis with symptoms like fever, chills, vomiting, and costovertebral angle tenderness. So furthermore, specialist referral for recurrent uncomplicated UTI is indicated when risk factors for complicated UTI are present, and referral is also indicated when you find a surgically correctable cause of UTI is suspected and the diagnosis is sometimes uncertain. Prior to referral, it's a good idea to do a urine culture while the patient is symptomatic and 2 weeks following a sensitivity adjusted treatment, so that the clinician who the referral specialist will be able to evaluate further and manage this patient. So having said so much that this is a huge burden on our women, let's look at some preventive strategies here. The preventive strategies can be lifestyle modifications, continuous antibiotic prophylaxis, postcoital prophylaxis, non-antibiotic prevention strategies like estrogen therapy, cranberry juice, ascorbic acid, methenamine. We'll be talking about these in detail. Emerging therapies like D-mannose, lactobacillus, probiotics, and vaccination, which are all in the pipeline. So coming to lifestyle modifications, these patients should be informed and educated about behavioral risk factors, especially sexual activity. They have to be educated about multiple sexual partners. It's very important to identify what contraceptive they are using. Spermicidal agents are notorious. Even when used with a condom, they can be a risk factor for recurrent UTI. So you can give them alternate forms of contraception. A lot of myths need to be cleared up with these patients. A number of studies have actually failed to demonstrate any association between recurrent UTIs and pre- or post-coital voiding patterns, frequency of urination, delayed voiding habits, wiping patterns, douching, use of hot tubs, bubble baths, BMI, tight clothing, type of clothing, bicycle riding, and the volume of fluid consumed. Although we still continue to look at factors like asking them to avoid post-coitus, wiping from front to back, increasing the frequency of urination, etc. But objectively, studies have not reported any improvement in these practices. Coming to continuous antibiotic prophylaxis, this is perhaps the most important strategy for prevention of any future episodes. A Cochrane review has, many Cochrane reviews have identified that continuous antibiotic prophylaxis reduces rate of recurrent uncomplicated UTIs in both pre and postmenopausal women when compared with placebos. And nitrofurantoin in many studies was supposed to be the most effective, reducing the UTI rate to 0.4 UTIs per year. There are no specific guidelines on the duration of continuous antibiotic prophylaxis. However, 6 months of treatment followed by observation for reinfection remains an empiric recommendation. So these are the antibiotics that are frequently used and recommended. Trimethoprim with sulfamethoxazole, trimethoprim. Actually, trimethoprim is associated with a lot of high recurrence rate due to resistance. Nitrofurantoin is perhaps the best at bedtime, once daily at bedtime. Cephalexin, ciprofloxacin, norfloxacin, ofloxacin, and fosfomycin, which is now the latest one, 3 grams every 10 days can be utilized. Coming to postcoital prophylaxis, again, it is one of the most important strategies in sexually active women, where frequency of sexual intercourse is a real risk factor. A Cochrane review has found that postcoital prophylaxis is equally effective with as a low-dose continuous antibiotic prophylaxis in the prevention of recurrent UTI, with the advantages that it is required in smaller amounts than continuous prophylaxis and thereby associated with fewer side effects. Some of the same agents that are used for postcoital prophylaxis, trimethoprim, sulfamethoxazole, nitrofurantoin, cephalexin, ciprofloxacin, ofloxacin, and norfloxacin. Coming to estrogen therapy, we all know that postmenopausal status is a condition of estrogen deficiency and thereby lack of lactobacillus in the vaginal mucosa, the altered pH, altered vascularity, and immune response is also altered. Thereby, many studies have reported a significant decrease in UTIs among postmenopausal women when vaginal estrogen creams were used. Especially the dosage is use them every night for 2 weeks and then twice a week for almost 6 to 8 months. This gave a very good result compared with those using a placebo. However, your oral estrogen tablets are not of much use. Vaginal estrogen is very safe. Systemic absorption is very negligible and there is hardly any side effect, except in cases of malignancy, genital tract malignancy, they are very safe. Coming to cranberry juice, a lot is debated about cranberry juice. Cochrane review of 24 studies with a total of 4,473 subjects revealed that cranberry products were actually of no benefit compared to placebo in most populations, whereas there was another meta-analysis that found the number of events actually halved. In any case, cranberry juice is a good antioxidant. It's easily available and it's good for the heart as well, and patients can definitely try them. Ascorbic acid has been recommended as a preventive measure for recurrent UTIs because of the acidification of urine, but actually a lot of in vitro studies suggest that it has a bacteriostatic effect on the urine mediated by the reduction of urinary nitrates to reactive nitrogen oxides rather than by lowering the urinary pH. Methanamine salts, again, they are hydrolyzed to ammonia and formaldehyde when in acidic urine, and they act as a bactericide to some strains of bacteria. They're well tolerated and have very minimal side effects, especially gastrointestinal rashes, anorexia, and stomatitis, and they can be an attractive agent for recurrent UTI prophylaxis. A small number of studies have actually compared methanamine hippurate with placebo in healthy pre- and postmenopausal women and found that at the end of 12 months, there is a definite reduction in the recurrence rate. A Cochrane review on the use of methanamine hippurate actually concluded that short-term use is effective in preventing recurrent UTIs in women without urinary tract abnormalities or a neuropathic bladder. Coming to D-mannose, which is being hyped up by many of the pharma companies, I should say. D-mannose is a sugar normally present in human metabolism and has an important role. The mechanism of action is through inhibition of bacterial adherence to urothelial cells. In vitro and in vivo studies have actually shown that D-mannose causes saturation of the FMH adhesion molecule, which is positioned at the tip of the fimbriae of enteric bacteria and on the urothelial epithelium of the urinary tract, and thereby they prevent bacterial adhesion to the urinary tract. There is only one randomized controlled trial, if I'm sure, if I'm not mistaken, done amongst 308 women more than 18 years of age with acute UTI and a history of recurrent UTIs. The subjects were divided into 3 groups. The first group received daily D-mannose prophylaxis for 6 months. The second group received continuous antibiotic prophylaxis with nitrofurantoin, and the third did not receive any prophylaxis. And the researchers actually found that in the group where the patients did not receive any prophylaxis, the incidence of recurrent UTI was as high as 60%, in contrast with those receiving D-mannose and nitrofurantoin. But between D-mannose and nitrofurantoin, there was not much significant difference. The only side effect of D-mannose being little diarrhea, but it's not bad enough for discontinuation. The authors, however, have concluded that further clinical trials are needed to validate the results of their study. Coming to lactobacillus and probiotics have come in a big way, even in many conditions, even in PCOS. This is a novel approach to reducing the risk of recurrent urinary tract infections. A recent phase 2 trial involving 100 premenopausal women with a history of at least one UTI in the last 12 months actually found a significant reduction in the incidence of recurrent UTIs in women receiving intravaginal lactobacillus as compared to those in the placebo group. Lactobacillus, however, in some subsequent trials where the subjects were randomly assigned to antibiotic versus lactobacillus, they found that the subjects using only lactobacillus had more frequent recurrences over the year and shorter time to recurrence. Thereby, further research is required before they can be recommended as a preventive measure, as a single preventive measure, I mean. A lot has been coming up in the form of vaccines, which are the emerging techniques. Urovaxum is an oral capsular vaccine comprising of 18 heat-killed E. coli strains, because that is the predominant organism. A meta-analysis of 4 studies comprising 891 patients demonstrated that Urovaxum significantly reduced the risk of development of UTI compared to placebos. Urovac is another vaginal suppository vaccine which has yielded positive results. It comprises of 10 uropathogenic strains of bacteria, 6 E. coli strains, and 1 strain each of Proteus mirabilis, Morganella morgani, Klebsiella, and Enterococcus faecalis. And currently, this vaccine has been successfully completed a phase 2 trial. The important thing is the primary immunization plus a booster vaccination is effective in prolonging the time until first recurrence of UTI as compared to participants who did not use the vaccine. And what was significant was primary immunization alone without a booster did not show equal effects. MV140 is another vaccine, is a polybacterial sublingual vaccine consisting of multiple organisms like E. coli, Klebsiella, Enterococcus faecalis, Proteus vulgaris, etc. It induces a T cell specific adaptive and an immune response at the genitourinary tract levels. The results found that 1,408 women who were treated with this had significantly higher UTI-free rates compared to 499 women who were treated with antibiotics alone. Additionally, Additionally, the RCTs also revealed a higher UTI-free rates, while the placebo group exhibited a lower UTI-free rates. So the recommendation for the pathway for evaluation and management of recurrent UTIs, just a second, the patient usually presents with, the patient usually presents with dysuria, frequency, urgency, suprapubic pain, flank tenderness, fever, hematuria, and it's very important to take a proper history, confirm that it is a recurrent UTI, history examination, as well as urine cultures. And if we are going to find risk factors for complicated UTI, immediate referral to specialists, as well as for imaging, cystoscopy, etc., and treatment of the underlying cause is required. If there are no risk factors identified, then you can treat them as uncomplicated UTI with antibiotics, which are depending on the urine culture reports. A repeat culture in 2 weeks post-antibiotic treatment is very important in identifying bacterial persistence or a relapse. And if there is no resolution, then you refer them to for secondary care to specialists. And if there is a complete resolution, then we reinstate preventive measures like self-initiated therapy. In actually educated people, you can use a self-initiated therapy if they are compliant and reliable. Prophylactic antibiotics, which comprise of continuous antibiotic or a postcoital antibiotic. Lifestyle modifications with adjuvants like cranberry, vitamin C, methylamine salts, etc. And in postmenopausal women, we can add vaginal estrogen cream or ring or any method. I think my slide is not moving. Yeah, to conclude, recurrent UTIs are common phenomena occurring in both pre and postmenopausal women. It is important to identify those patients with recurrences through appropriate history and examination. Risk factors should be identified and addressed accordingly. Antibiotics still remain the most effective method of management. The type and regimen of antibiotic agent should be individualized to each patient. Non-antibiotic prevention strategies such as cranberry, vitamin C, and methylamine salts actually lack strong evidence to be introduced as routine management options or as alternatives to antibiotics, but they can be used in conjunction with antibiotics for whatever it is worth, because the side effects are minimal. So thank you for your patient hearing, and special thanks to Dr. Archana Verma for having me over today, and to all the delegates for this patient hearing. Thank you.
Thank you, Dr. Deepa. Very amazing and informative talk. Thank you so much for that. And at the outset, I would like to thank Madam Archana Verma for making me a part of this wonderful webinar. I've heard all the topics, all the panel discussion also, and it was really very informative and wonderful. Coming to this topic, Dr. Deepa, it was great to hear about methylamine salt and the Euro vaccines, because even that was new information for me. But I would just like to highlight a few simple points that we should go into the history about the details of the liquid or the water intake which the patient takes, because there are very few ladies who take around 3 liters of water or liquid in any form. Usually their intake is poor. And the other important thing is the menstrual hygiene. Menstrual hygiene is very, very important, because this, there are certain ladies who over clean themselves, and there are certain who are very careless about that. They use frequent cleansers, the perfumes, and many other agents which can be irritating and can lead to recurrent UTI, the douches, etc. And there are certain ladies who don't care about the hygiene part. So that is very, very important. Furthermore, regarding the antibiotic use, we should be careful about the pH of the urine also, besides the culture, because there are certain antibiotics which work better in alkaline medium, and there are certain which work better in the acidic medium. That is the talking about nitrofurantoin, which is the best antibiotic. It should always be given with along with the alkalizer, because it might lead to crystalluria, etc. So that is very, very important. And the second thing is the cephalosporin group and other antibiotics, they work well in acidic medium. So adding vitamin C would be a good alternative. So Overall, it was a wonderful webinar, very, very informative. And thank you so much, Dr. Deepa. Thank you so much, Dr. Archana, ma'am. Thank you.
Thank you so much for the additional inputs, ma'am. Actually, urinary tract infections, we usually give a concoction of urinary alkalizers or whatever, along with cranberry and antibiotic and all that. Yeah.
Yes, we should be, but we should be careful. If we are
Actually,
giving
cephalosporins, surprisingly, there have been some studies which have not objectively proven that, and there was a slide I presented. It was a surprise to me. They said that recurrent UTI has nothing to do with lifestyle practices of taking water, voiding frequently, wiping, and all that. So it was one slide where many studies have disproved that, even though even in practice, I do recommend all these.
Yeah. Okay. And my co-chair, Dr. Manisha, if she has to say anything. Over to you, ma'am.
No, very well presented, Dr. Deepa. And that's all what I want to say. Thank you.
Thank you so much, ma'am. Thank you.
Thank you, Dr. Deepa. Very excellent and mesmerizing talk. We are overwhelmed. Thank you so much.
Thank you so much.
Now it's time to give official vote of thanks. I invite Dr. Rashmi Sharma. Kindly give vote of thanks.
Dr. Deepa, it was wonderful.
Thank you, ma'am. Thanks so much for the opportunity. I owe everything to you.
Thank you.
No,
Thank you
this is Rekha Rajendra Kumar.
Yes, I really wish everyone to meet Deepa, because if you meet her in person, then you know how good a person can be.
Ma'am, such kind words. Thank you.
So
Thank you
sweet,
so much,
Dr. Archana.
Now I want.
गाजियाबाद बुला लीजिए ना फिर.
वो तो आएगी ही आएगी.
हाँ, अप्रैल मई जून कभी भी बुला लीजिए.
Very soon we are inviting all under guidance of Dr. Archana Verma.
Sure, it'll be a real pleasure to meet you all in person.
So it's time for official thank you. So first of all, I would like to thank our international speakers who have joined from other side of the globe, sitting in different time zone in their busy working schedule. Thank you so much. And thank you so much, Dr. Deepa, our national coordinator, who coordinated so well with them and who gave lucid talk. Thank you, Deepa ma'am. Thank you so much, our chief guest, Dr. Narendra Malhotra sir, Dr. Nandita ma'am, and Dr. Sneha ma'am, who joined us they are special guest of honor for us. And thank you so much, our esteemed panelists and moderators. And I would like to thank pillar of ISOPARB West UP, Dr. Archana Verma ma'am, who gave birth to our ISOPARB and now nurturing it very well to become a wise young adult. And I would like to thank our pretty secretary, Dr. Seema ma'am, who is always ready to help us. And last but not the least, I'll just thank our pharma company, who just, without their support, it was not possible. So thank you, our pharma company.
All the chairpersons, we are grateful to
all
them.
The chairpersons and all the speakers, we are thankful to all of you.
And the audience also.
And the delegates also. Thank you so much, all of you. And now I wish you have a happy Holi and have a happy and safe Holi to all of you. Thank you so much.
Happy Holi to all of you. Bye-bye. Take care.
Just before closing, Deepika, mera special thanks. I mean, no words to say thanks to Deepika, who just joined on my request to just come and handle this webinar, and two vibrant, a really vibrant pupil, gems of the ISOPARB, Dr. Renu Goyal and Dr. Rashmi. Both of you have proved that if someone can do and want and apne mein andar se na, I mean, interest ho, so you can do the things so nicely. Just see, it is your efforts, totally your vision. You people have done wonderful job, and I really wish you all the best. अपने आप से आगे आना, अपने आप से पूरा आगे आए. मैडम, अब की बार हमको करना है. Okay, आ जाओ. सब कुछ करा. This is something very good, and this is a change. I think this is a change I'm seeing people coming forward and asking them that ab humko karna hai. So this is something very good, and I really appeal to all jisko talk bhi dena hai, please give a little bit information and your interest to us. We will definitely do this thing, because this platform is only for this type of things only. It was my pledge and it was Seema's vision that we have to take ISOPARB, West UP ISOPARB forward, and we want to involve each and every person. जो थोड़ा शर्माएगा, जो थोड़ा ego में रहेगा, issue उसी को आएगा. बाकी come forward, and it is only and only your organization. Don't hesitate.
So, ma'am, Jagsonpal also takes this opportunity to thank everybody.
Thank you, Dr.
Yeah.
Thank you, Dr.
Thank you once again for your presence today. And we request to your support to our newest brand in our product portfolio, DIVATRONE, 10 mg tablets of micronized dydrogesterone. Please join us on 22nd March at 7 p.m. for another webinar on Pearls of Wisdom by Society of Meaningful Life Management. Please note down the Zoom ID displayed and register now. Thank you, and wishing all a happy, safe Festival of Colors, Holi.
Happy Holi.
Happy Holi.
Thank you.